come to this morning's section. As Jason rightly said, this is the last and final day of our meetings, and we'll give it a good push to make sure that we finish well. We're going to have three major subject areas that we're going to discuss this morning and early afternoon. We want to look at the important subject of subnational tailoring. I think this has been echoed a lot throughout the presentations from Tuesday. We will deep dive into that. Then we look at the strategic decisions that we need to make with respect to the various channel mix that we do have for delivering ITNs targeting the populations at risk. And we're going to have country lessons presented to us from the team in Nigeria and then Zambia. And then we will end with how we're going to optimize ITN operations and make sure that we bring effectiveness into our operations as we deliver ITNs. And here we'll be looking at lessons from Ivory Coast, Sierra Leone, and then Kenya. And then finally, the final section is focused on routine distribution, and we will be having presentation by Sophia Kaufman of Chai and with Cameroon, who will be presenting an assessment of the routine ITN distribution systems and key steps for strengthening the channel. And so without wasting much time, I would want to invite the first presenter, Andrew Glover of the Imperial College London, to walk us through the first subject of subnational tailoring. Over to you, Andrew.
Is this working? Can everyone hear me? Yep, great. Okay, can I have the slides on the screen? There we go. Okay, so I'm Andrew Glover. I'm a mathematical modeler from Imperial College London, and today I'm going to be talking about sort of strategies that we can sort of start thinking about if we want to subnationally tailor ITN interventions to maximize impact. Let me just get the clicker. There we go. So when we're thinking about subnational tailoring of ITN interventions, there are two things we need to be thinking about. What ITN interventions should be prioritized, what channels should we be focused on, and which ITN types, so pyrethroid only, PBO, clofenapir ITNs. They're the three that we're just going to be looking at in this presentation, but also we want to be thinking about where should those interventions be prioritized. Should we only focus on regions with high transmission intensity, or should we be thinking about other factors such as short retention time? Should we be distributing nets more frequently to those areas? And also potentially areas of low use given access. Again, are those potentially regions where we should be distributing maybe more nets so that we have potentially more equitable and subsequently more impactful outcomes? Sorry, can I have the next slide? There we go. So in the first part of this presentation, I'm going to be focusing on effectiveness. So we're just going to be looking at initially in terms of what characteristics of different regions lead to different ITN interventions being more impactful. Then we'll move on to cost effectiveness and how we can use that to have optimally cost-effective subnationally tailored strategies. And we'll talk a little bit about different ways that we can think about achieving that. So thankfully, all the simulations that we've kind of looked at do thankfully align with a lot of guidance, which is very much focused on giving subnational tailoring guidance on the basis of transmission intensity. So we do find, thankfully, that that is a good predictor of impact of different ITN interventions. So I'm now just going to talk through this slightly complicated figure on the right. So what we've done here, on the x-axis we have our estimates of clinical cases per 1,000 people with a 3-year PBO strategy. And on the y-axis, we have our predictions on the change in cases if we switch to different strategies. So in the left-hand column, we have our predictions for if we only have continuous distribution. In the middle, we have our estimates if we have continuous distribution plus 3 yearly mass campaigns. And on the right, we have our estimates if we have continuous distribution plus 2 yearly mass campaigns. Now, in the top row, we have pyrethroidone nets, and then followed by PBO, and then chlorphenapyr, going from top to bottom. So that's why in the central panel, all of the y-axis values are 0, because we're basically saying if we switch from a 3-year PBO strategy to a 3-year PBO strategy, we're not estimating a change. Okay, so what we can kind of see is that we see fairly similar trends when we look at, across different countries. So the different colors are for the different countries we were looking at. So we can see that moderate and high transmission settings are more likely to benefit from increasing the frequency of mass campaigns. It's not a linear relationship. Often we do find that there's a much greater increase in benefit when you go from a sort of lower transmission setting to a moderate one than from a moderate one to a higher one. And we see a very similar relationship again if we, when we're estimating the impact of switching from PBO to chlorphenapyr nets, where we're estimating you would get more impactful outcomes in moderate and high transmission settings. Conversely, also, another way we can look at this plot is what would potentially happen if we deprioritized areas, and that's basically illustrated by panel D, which is showing our estimate in the change in cases if you deprioritized mass campaigns but still stuck with continuous distribution of PBO nets, and we can see that we're estimating the greatest impact in moderate and high transmission intensity regions, but again, we don't estimate a linear relationship. We do estimate that though particularly low transmission regions may not have a significant increase in cases, there's again far more of a difference between going from a low transmission setting to a moderate one than from a moderate one to a high one. So yes, so that was us looking at the relationship between transmission intensity and the impact of switching to different strategies in different regions, but we also looked at, does anything else matter? Should we be thinking about other things aside from transmission intensity? So this plot here, I'm showing our estimates of use given access for all of the different regions that we looked at, and we can see a similar relationship between the predicted impact from switching to different strategies versus use given access, where broadly speaking, regions where nets are more likely to be used, so that's towards the right of each panel, they're regions where we would expect there to be more cases averted with either increasing campaign frequency or moving from say PBO nets to chlorphenapyr nets. And conversely, again, we're estimating that in areas where you have higher use given access, you may actually have greater increases in cases in those regions if you were to deprioritize campaigns. Now, I should emphasize, this is assuming that use given access doesn't change, and also there could be other factors associated with this, such as you could have different net products, going back to yesterday, that may not have particularly good resistance to damage scores, and that may be a driver of this rather than behavior. So just wanted to emphasize that. So now if I move on to cost effectiveness, here we go. So what we then have been sort of playing around with, we've been looking at situations such as this one, which is an example for Mali. So on the left here, we've generated estimates of how many clinical cases there would be annually if we conducted 3-year distribution of PBO nets everywhere. what we've then done, we've done some work to try and efficiently estimate what would be the most optimal strategy given a selection of different options that are available to us, and we're trying to optimize this for the same budget. So both of these plots we've estimated would have broadly similar costs, but on the optimized strategy, we've switched to chlorphenapir nets in virtually every area, apart from the northern region of Timbuktu. I should also highlight Kidal in the northeast. We didn't include in the analysis just because we didn't have enough data on that. But aside from that, every other region we have chlorphenapir nets, so that's indicated by having the black cross-hatching and diagonal lines, as opposed to the grey slanted lines which indicate PBO nets. But what we've also done, we've got some 2-year distribution of mass campaigns in the very high transmission southern regions, whereas we've deprioritized campaigns entirely in the capital and the relatively lower transmission setting of Gao in the east. So on the right, sorry, you've got me slightly in the way of the legend. There are estimates of the additional annual clinical cases averted, thank you for removing me, for the different regions. So we can see that in the much higher transmission southern regions, we're estimating we could avert potentially as much as around 150 clinical cases per 1,000 by having this very targeted but very expensive 2-year chlorphenapir strategy, although as the trade-off is a slight increase in cases in the region of Gao where we've deprioritized entirely, although the additional cases that we're estimating here are around about 20 to 30 per 1,000, but we're estimating we could maybe avert 150 per 1,000 in the southern region. So again, obviously this raises lots of questions around equity and obviously, absolutely that is something that should be considered. This approach here is solely taking a very utilitarian approach and just strictly looking at how can we maximize cases nationally per US dollar. This approach isn't taking equity into consideration at all. And I should emphasize, I'm not saying you shouldn't take equity into consideration. I'm just saying this approach isn't. So the next thing, so this is just sort of to show how we generate maps such as that. So what we've done, we've kind of looked at a various range of different potential annual budgets. I've just selected a subset of regions in Mali just so this isn't an overwhelming slide. And what we basically do is for, in this sort of predominantly blue sort of heat map on the left, we have basically, we've estimated what would be the optimal national strategy if we conduct different strategies in each region. So in terms of the colors, all of the blue colors are indicating chlorphenapir strategies, green would indicate a PBO strategy, and orange would indicate a pyrethroid-only strategy. So the very clear thing you can see straight away, that's basically all blue. So we are very confident that basically at every single range of that budget space, that the most optimal strategy will be to distribute chlorphenapir nets. However, to achieve that within each of these different budget levels, we're not conducting the same strategy everywhere. We are doing subnational tailoring. So the darkest regions indicate where we're doing mass campaigns every 2 years. I apologize, it's a little bit trickier to see, but there's a sort of moderately shaded blue, which indicates 3 yearly campaigns. And there are areas with a very light shade of blue, which is where we're doing a bit of continuous distribution. Now, this sort of plot on the top, that's showing our, the black line is showing our estimates of clinical cases averted if we conducted these optimal strategies. Now, those coloured dots that are overlaid are if we did a universal strategy in every single setting. So on the left-hand side, we've got our estimates if we just conduct continuous distribution with PBO nets in light orange, followed by PBO, and then clofenapir in green and blue. So that left block, that's all continuous only distribution here. Then that central block is 3 yearly mass campaigns plus continuous distribution, and then 2 yearly mass campaigns. So one thing I want to highlight there is our estimate of conducting 3 yearly mass campaigns with continuous distribution with pyrethroid-only nets. We are estimating that would avert a similar number of cases as deprioritizing mass campaigns entirely and only relying on continuous distribution with clofenapir nets. I will emphasize that is for this one scenario here in Mali where we did estimate that there was there to be slightly more continuous distribution than in some other settings that we looked at. But this is just to sort of highlight that distributing as many nets as possible doesn't necessarily have the most impact. What matters significantly is what nets you're actually distributing. Again, could I just move myself away? Thank you. So also I wanted to highlight, although we have been looking at having a mixture of continuous only 3-year or 2-year mass campaigns, I'm aware that there may not be much of an appetite for having 2-year campaigns anywhere. So we did also repeat the analysis with only looking at 3-year intervals as a mass campaign option. And again, we see a very similar pattern where clofenapir strategies are dominated in terms of the optimal mix. And another point as well I want to highlight, which I'm not sure I did before, is that the regions here are plotted in order from lowest transmission intensity to highest transmission intensity. And we broadly see that at lower budget levels, broadly speaking, we have higher transmission intensity settings prioritized first. It's not a perfect relationship. A lot of that is, again, going back to what I was saying before, is driven by other factors, such as use given access and retention time, because ultimately, when nets are more likely to be used and more likely to be used for longer, interventions are more impactful. So that often can sort of help explain some of the different differences, but we do, broadly speaking, if you don't have data on those things, broadly we find that prioritizing on the basis of transmission intensity is still a sensible way to go. Can I have the next? Okay, so we've now got a quick group activity on how we can achieve more with less, and I'm going to get everyone in the room to do some mathematical modelling. Great first thing to do on a Friday morning. So on this side of the room, we have our orange team, and over here we've got our green team. Now, both teams are in regions with high transmission and high pyrethroid resistance. And earlier, I distributed some ITNs to your tables. So this orange team, you've got your orange ITNs, and we should have green ITNs over here. So what I want you to do is randomly select people on your table, and I want you to use your ITNs. So can I have everyone who's able to, can you use your ITN? Now, there isn't enough for universal coverage. That is intentional. Okay. Great. Has everyone got their ITNs? Great. So broadly speaking, this side of the room, we've broadly got 66% use. Over here, we've broadly got 50% use. Now, that's roughly speaking similar to having a mass campaign where we're distributing one net for three people over there and one per two over here. There's a slight difference between how number of nets distributed converts into use, but I can talk to people later about that. But broadly speaking, as I say, we have a sort of status quo, higher coverage approach over here and a lower coverage approach over there. So the next thing I want people to do is I'm going to focus on the orange team first. So on the orange team, can I go next? I'm struggling with the clicker. Okay, so people on the orange team who are using an ITN, if you were born between the 1st and 8th of any month, I want you to stand up. Only people who are using an orange ITN. So that's definitely everyone who was born between the 1st and 8th of any month who was wearing or using that orange ITN, they're stood up. Yes? Great. Okay. So now, I'm not totally crazy, by the way. So the probability of you being born then was 26%. Okay? Just nice little fact. Now, for the remaining people on the orange team who don't have an ITN, if you were born between the 1st and the 13th of any month, I want you to stand up. Now, the probability of you being born then was 43%. Okay? Now, going over to the other side of the room, if you have a green ITN and you're using it, please stand up if you were born between the 1st and 5th of any month. So that's everyone using a green ITN born between the 1st and 5th. Okay, great. So you had a 16% probability of being born then. And I can go to the next slide. Now, for people who don't have an ITN on the green team, please stand up if you were born between the 1st and 8th. Again, of any month. Okay? Hoping this will work. So, why did I get you all to stand up in that way? Can I have the next, please? Okay. So the reason I did that, they are roughly the probability of being infected in each of these groups per week, 6 months after distribution, if the orange ITNs were pyrethroid only and the green ones were pyrethroid chlorphenapyr. Now I want to emphasize, I'm talking about infections here, I'm not talking about cases. It's just a little bit easier to translate into this context in the room than actual cases. You will have far fewer cases per week, but broadly speaking, when you have more infections, you have more cases. It's not a linear relationship, but broadly speaking, if everything had gone to plan, which not totally sure about, I think slightly, we should, in theory, had everyone had a nice distribution of birthdays, there should be more people infected on this side of the room with more nets than the lower coverage of chlorphenapyr nets over there. And I have to emphasize, I've not totally made up those numbers. I did try and roughly make them realistic. But yes, hopefully that helps show some key important things. You may notice there are two common percentages here. Broadly speaking, people who are in this community who aren't using an ITN have actually the same probability, roughly speaking, as the individuals in this community who are using an ITN. So that sort of goes to show that it's not, we don't really want to be necessarily focused on maximizing coverage for maximum impact, especially when we have so many different products, and that, as I say, we should be focused on maximizing coverage with the best available product to us. Okay, you can sit down now. Feel free to keep using or stop using your ITN. So finally, yes, back to something a little bit less fun, but broadly speaking, what the Orange team were doing, they were broadly doing this. They were broadly simulating our status quo scenario. In this scenario, our status quo, I know this is a status quo from a while ago, but the status quo for this simulation was if we had distributing one net for 2 people with pyrethroid only. That's our kind of status quo. And what we had on the green team was, roughly speaking, distributing 1 net per 3 people. And that would be with chlorphenipionets, which, as we all know, they are more expensive, but we are distributing fewer of them. Now, they were actually simulating, broadly speaking, that bottom scenario here. Now, if we have a fixed distribution cost per net, broadly speaking, that cost about 25% less than that. That was with fewer nets, and we are estimating that would cost less and have more of an impact. However, that is a very big assumption to assume that we will have a fixed cost, a fixed distribution cost per net as we start thinking about reduced coverage campaigns. That is something that we are going to be looking at in more detail with collaborators. So as I say, broadly speaking, if distribution costs per net aren't going to change drastically, we still will hopefully be able to achieve more with less. So finally, yes, just to summarize, moderate and high transmission intensity regions are more likely to benefit from more campaigns and chlorphenipionets, and nets are more impactful where they're more likely to be used and used for longer, and that prioritizing chlorphenipionets is very important for optimal cost effectiveness. And as we're moving forward, we will need to start thinking about new distribution strategies to help us achieve more with less, such as under 5 campaigns or reduced coverage campaigns. So finally, if you remember one thing from today, fewer, better nets can avert more cases. Thank you.
Very good presentation. Thanks so much, Andrew. In the interest of time, we will allow for only 2 questions. And so, do we have any hands? Okay. Yes, 1. Any other side? Okay, please go for it. Yes, please ask the question. Yeah. Oh.
Hello. Thank you, Andrew, for your presentation about subnational tailoring. What I am just like a comment that with the optimal, like we have less kind of funding, maybe we are seeing in GC8. So like in Pakistan, we have people are buying mosquito nets. That is not insecticidal nets, but still they are available. People are having protection like physical barrier. So if it is possible, then we can make it in like commodity in a market. There's insecticidal treated nets and also the PBO nets, if it is okay, that it should be available in market. So people, I think, will buy from market, being life is a precious thing for everyone. Just a comment like that.
Yeah, broadly speaking, obviously, the private market will be important in a lot of contexts. On the point on when you have more distribution of untreated nets, you'll have a sort of even worse potential outcomes than, say, a pyrethroid-only net in a high transmission setting. If it's untreated, you won't have that community effect, which hopefully we saw in the group activity is impactful. It's not to say that it won't have any effect, but well, we do kind of estimate in a lot of our models that the community effect is very important.
Hello. Oh, that is working. So you're talking about the community effect being greater for the chlorphenapine nets. Could you talk about the mechanism of that a little bit? Is it because it's killing more versus repelling less?
Yeah. So a chlorphenapine net, we have estimated would both repel more and kill more than a pyrethroid-only net in most settings. So the way that we've estimated that in our group is we've estimated the degree of repellency and probability of mortality at different levels of pyrethroid resistance from experimental HUT trial data, and then we validated that against cluster randomized trials. And from our estimates, we do estimate that chlorphenapine nets both have a greater probability of repellency and mortality, but you're absolutely right, it's that greater probability of mortality that's suppressing the mosquito population, which is leading to that community effect in the model. Yeah.
Okay, I'll take a final one very quick. Yes. Yes, you can try your mic.
Okay. Sorry, this was meant to be quick. Can you hear me? Thank you, very thought-provoking. I was just wondering if your modeling spoke to the trade-off between excluding areas completely versus changing the people-to-net ratio. So, for example, in a province, you don't have enough funding to do all nets with one net for 2 people, and the options that you would be looking at is, assuming we're going to buy chlorphenapine nets, you could either exclude districts entirely, or you could increase the people per net ratio and then include all the districts within that province. Does your modeling talk to which of those options would be more beneficial, assuming that we had the same transmission across that area?
So what we've been doing, we've been approaching those 2 scenarios separately. So the slides I showed in the middle where we had those sort of blue bars, that was basically optimizing on sort of existing approaches, continuous distribution and mass campaigns. We were playing about with the frequency of them, but we weren't considering reduced coverage campaigns. What we then separately have been looking at is just reducing coverage universally everywhere. What we are intending on doing is trying to get better estimates of, say, what coverage would look like with an under 5 campaign, and then throwing that into the mix of potential different strategies, so we can kind of then have an optimal scenario that may have some mass campaigns still in some regions, and then maybe under 5 campaigns in others, rather than just saying campaign or no campaign. That's something we're doing in terms of kind of then looking at if we can tailor things at finer scales. It's quite difficult for us to do that at scales lower than an admin 1 level. So that's kind of the first level of division below a country. So yeah, we're kind of a bit limited in going to finer scales than that, simply because of availability of data.
All right, thanks so much, Andrew. You may take your seats. Let's appreciate Andrew as he takes his seat. That was a very good presentation. We will now focus the discussion on channel decision making, and I would like to invite Fatima from Nigeria and Katie from Zambia. That's fine. All right. So Fatma, you have a maximum of 20 minutes, and same for Katie, after which we will have time for Q&A. Over to you, Fatma.
Okay. Good morning, everyone. My name is Fatima Ali, presenting on behalf of NMEP Nigeria. Next slide. Okay. Just an outline of the presentation. Next slide. So, the background in Nigeria is historically we have relied on mass campaign every 3 years as our primary channel of getting ITNs into the household. This is complemented by routine distribution to ANC and EPI as a secondary complementary channel of distribution. However, due to current realities of epidemiological shift, finances, and demographics, there is need to be more adaptive and move away from one uniform fits-all approach to more adaptive, data-driven, context-specific, subnational, tailored approach to channel selection. So, like I said, we use the mass campaign as the primary delivery platform, then the routine. And nets typically last 2 to 2.5 years. And I think from previous presentations in this meeting, it has shown that some nets even last less than 2 years. So that means gaps emerge before the next campaign 3 years later. So, and then we have a limited structured framework for channel distribution in Nigeria. Our guideline for continuous distribution, for example, was last updated 2015. So that's quite a long time. So there's need to update it to accommodate the current realities and give proper guidance to the country. We also have challenges of shrinking funding, not just specific to Nigeria. This is a global problem. Like in the global fund states in Nigeria, for the last grant, the GC7, we had only 70% of the ITN need. And as we all know, this is likely to be shrinked further in the next grant. We have increased urbanization. Just like any other country, more people are moving from rural to urban. So this shifts the definition of where you have high burden malaria and considerations of urban malaria strategy, and also the population shift between urban and rural. Changing epidemiology and resistant patterns. Nigeria recently discovered the Anopheles stephensi, so those are the kind of changes and vector changes, and then resistance to the different insecticide are being discovered every time the vector is adapting to the insecticide, and we have resistance issues. Then we have a growing commercial and private sector presence, and then of course to consider the global shift, the WHO guideline guidance of good practice from just universal coverage, but to more optimal targeted optimization of delivery. Next slide. So just to remind us all, the main channels of distribution for ITNs are mass campaigns. In our case, we do them subnationally, statewide, so we have rolling campaigns every year. And then ANC distribution for the pregnant women, EPI through the immunization services, school-based distribution, commercial and the private sector, and then the social marketing where nets are subsidized through a structured private sector engagement. So like I said, we have heavy reliance on campaigns for rapid scale up. So that's the push approach. The routine channels, especially the ANC and EPI, we have a good structure on ground, but they are not optimized as they should be. And then we have a good structure for the private sector, but it's not optimized properly. So in theory, we have a multi-channel structure on ground, but we are not properly utilizing it in Nigeria. Next slide. So how do we move from that one-size-fits-all of universal coverage, rolling campaigns, to a more data-driven, context-specific channel mix to optimize resources and coverage at that subnational level? So some of the things we're already doing is integration of ITN and SMC. My colleague from Nigeria gave a presentation earlier, and that has enabled us maximize resources and ensure efficiencies. Then we plan to pilot a mixed channel approach. We just finished or finalizing the review and update of our guideline, and the next step is to pilot school-based distribution in one of the states that are due in 2026. So it will be a combination of mass campaign and school-based distribution. And then development of a subnational reprioritization and channel selection tool. So we're working closely with AMP, WHO, Tropical Health to adapt the already existing AMP selection guidance to the context of Nigeria. So one size fits all is no longer viable. We're moving away from that. Next slide. So the question is, where and whom should we prioritize? So we recently finalized our new national strategic plan, and it has heavy emphasis on subnational tailoring. This has been done to state level and even to the local government level. So for each local government, even within a state, it tells you exactly what kind of malaria intervention that will be applicable to that. So that gives a good foundation to build on for ITN channel selection as well. The approach we're using is risk stratification, prioritize areas based on malaria burden and transmission patterns, urban-rural differentiation to look at the local epidemiology and the system capacity, and then mapping of vulnerable population, identify high-risk groups. So for example, you might identify an area to be more, to benefit more from a continuous distribution maybe, or to say school-based distribution. But if you have a high-risk population of pregnant women, then that means you have to take that into account as well. So channel selection, it's operational. It determines the most appropriate mix of ITN delivery channels for each. So these decisions have to be data-driven. You have to optimize impact over the reality of constrained resources, prioritize high burden, high need areas, improve equity, and reduce leakages and inefficiency. Next slide. So like I mentioned earlier, guidelines and tools are being updated with support from AMP. Channel selection guidance is also being finalized by support from AMP, Tropical Health, and WHO. We're leveraging on an assessment that was done on continuous distribution assessment. We're also integrating with existing digital and routine data platforms. Nigeria has a lot of experience and capacity on digital platforms, so we're riding on that. So in terms of urban reprioritization, we already have existing tools. We have the malaria program intervention and optimization tool. It's an Excel-based tool. Then we have the malaria reprioritization tools. It's an AI-enhanced tools. And we have the Shiny app, which is a web-based application. So what the data we use to impute to use these tools are the usual malaria burden, prevalence and incidence rate, ITN access and gaps, routine channel performance for EPI and ANC, school enrollment for school-based distribution, and most importantly, what are the resources that you have available. So this decision, this data helps us to take decision on targeted ITN distribution for mass campaign and continuous distribution, and where applicable the channel mix required, and what areas in terms of local government or wards to prioritize for specific distribution. So this data help us to have good evidence to back up our decision to do a channel mix or to tailor a particular channel to the right population at the right time and using the most effective delivery channels with the available limited resources. Next slide. Okay, so in just to give you a preview of the process that we have gone through, this started in 2024. We had a DEX review. Like I said, our guideline was updated a long time ago, so there was need to have stakeholder consultation at both the national and subnational level to identify what are the challenges, what are the gaps. Then based on that, there was a DEX review of the guidance. The guideline itself was reviewed, a draft was developed, and then indicators were standardized using the tools I've mentioned earlier. And currently we aligned it to the National Strategic Plan. The next step now is to pilot, like I mentioned earlier, in Osun State, and get experience and lessons learned and do it better in the subsequent states. Next slide. So what are the key challenges? Mindset is really important. Most countries, I believe, everybody is used to the mass campaign. Every 3 years we have a mass campaign. So it limits the mindset and innovation. So there is need to have good stakeholder engagement at different levels. That's why it's important to use data, because that gives you that justification and you're able to convince people to accept this new change. Funding is always a limitation now. So it's a big consideration that whatever limited resources you have, you should be able to adapt and optimize it as much as possible. You identify some areas to be eligible for routine distribution, but it turns out the attendance for ANC and EPI is quite low. So that's a huge challenge. So you have to do the back work of improving that attendance for routine distribution to work. Same for school enrollment. You can't do school distribution if you don't have good attendance of your target audience. And then you sometimes you have issues of reporting. For example, some health facilities are not very good at reporting their data. That gives a huge challenge in terms of using that data for decision making. You also have some boundary mismatch. I believe, like all countries, sometimes you have issues of identifying where one community ends and the other begins. However, we have emerging opportunities. The pilot in Osun State is very promising. We have started state engagement a long time ago to make sure they understand, and you keep repeating and engaging them and answering their questions, because state ownership is very, very important. If the state does not accept and own the process, you have a lot of challenges. We have the integrated IT and SMC campaign approach. We have learned that that has helped us gain efficiency in resources and even coverage. It has improved our coverage. I've mentioned about the early stakeholder engagement as early as possible for their buy-in, and linking and riding on the existing digital platform to improve real-time monitoring and getting data for quick decision making. Next slide. Okay, so what are the recommendations? To embed the channel selection in the National Malaria Strategic Plan and the annual operation plans. The AOPs are done at the state level annually, of course, so it's important that whatever resources that is needed or whatever gaps that are identified are communicated early to the state so that they can put it in their operational plan, and then that makes it easier to get the resources they need to fill the gap. State level justification for the mixed decision. So if you have your data and justification at that state level, local government level, it makes it easier to take decision. Of course, to finalize the guideline is almost done and disseminate it to all levels. And then most importantly, train all stakeholders at the national and state level so that everybody has the knowledge and understand the process. Strengthen the data system, improve routine reporting quality through the HMIS and DHIS, institutionalize IT and durability monitoring. This is very important to see how well nets are doing and in what context they're doing. Track commercial market share for total market planning. So like I said, we have a good foundation of the private sector, so it's just to utilize and optimize that channel. Building subnational capacity, training at all levels, and then to simplify the decision-making tools as much as possible. That way, at all levels, anybody can use it and anybody can understand it. Like I said, leverage on the pilot, get lessons learned, and improve for the subsequent states that implementation will take place. So, you know, the mixed channel approach in combination with the urban micro-stratification. Then strengthen reprioritization and national leadership. So, like I said, the National Strategic Plan advocate for increased domestic resources both at the national and state level. And then a lot of monitoring and lessons learned and improving performance and equity. So what in conclusion, key takeaway, we're shifting away from universal coverage to targeted campaigns, prioritize high burden LGAs, optimize impact per dollar, better align channels to epidemiology and need, use data for reprioritization to arrive at a consensus despite some difficult trade-offs that might be needed, and strengthen sustainability. So in conclusion, it's not just about replacing mass campaign. Mass campaigns can still take place, but it should be targeted and tailored to exactly where it's needed, based on data, context, and sustainability. I think that's my last slide.
All right, thanks so much.
Thank
Right on
you.
time. Fatima, you can take your seat as we invite Katie to present the lessons on channel selection decision making with respect to Zambia. Over.
Good morning, everyone. So my name is Katie Glovo, representing the Zambia National Malaria Program. And today I will be taking you through the strategic shift that Zambia has taken with regards to tailoring and prioritizing ITN distribution channel for 2026. Next slide. So this is just the outline. Next slide. In Zambia, as you may be aware, malaria is of profound economic problem. And as much as we have declining cases in certain districts, transmission is heterogeneous across the country. And there is need to maximize impact by ITN distributed and also in alignment with our strategic focus for elimination. Next slide. So the ITN program is deeply rooted into the NMA, the strategic plan 2022 to 2026, which prioritizes stratification and efficiency. And according to our strategic plan, we have stratified our vector control interventions according to 4 epidemiological strata. We have the very low, the moderate, and high. And in our current strategic plan, ITNs are the primary vector control intervention, which are complemented by other vector control strategies like RIS, LSM, and entomology. So in our current strategic plan, mass campaigns given priority to high burden areas, those in moderate to high epidemiological strata. Next slide. And for routine distribution, we've maintained nationwide, and we're doing routine distribution through ANC and EPI For ANC, we're giving nets to pregnant women at their first ANC visit. For EPI, we're giving nets to the under ones at the measles 9 vaccination visit. The strategic plan has also taken cognizance of the fact that we need additional channels such as school and community. We've done school distribution at a very small scale in Zambia. However, we are yet to also explore community distribution, probably in the next strategic plan, and also for low burden areas, we are managing them through surveillance-led responses. So this is just to show a summary of how we've stratified our vector control intervention. So you will see that mass campaigns are in the moderate to high, and continuous distribution in all epidemiological strata. Next slide. This slide is just to show how we've performed in the past 4 years with regards to routine ANC EPI. Over the years, we've had PMI strongly supporting specific districts or provinces with regards to routine. You will see that the coverage hasn't been really up to what we expect. However, what I wanted to mention here is, for the first time in the Zambian history, we had domestic funding, and the government of Zambia procured over 2 million nets for routine ANC EPI for 2024 cycle. And due to protracted procurements, we were initially supposed to receive these nets about first quarter 2024, but we received them in the fourth quarter 2024. That's why you see a spike with regards to coverage in 2025, because we've had nets that have gone round to all health facilities. And in addition to that, we have included nets in the electronic management system to ensure accountability of every net that is taken out there, and also visibility. And some of the key steps that we've taken into consideration are early initiation of procurement and front-loading of most of our funding. Next slide. So then, how do we prioritize our ITN distribution channels this year? And our strategic plan, by the way, is coming to an end this year. We'll be having our interim review, and we'll be starting to develop our new strategic plan. But according to our current, our focus for our ITN channels this year will include routine distribution countrywide through ANC and EPI, and mass campaigns in high burden areas in level 2 to 4. Next slide. For routine, this is what our quantification has been like. We are working with expected pregnancies, and the proportions that we are using is 4.47 according to our HMIS data, and also expected live births at 4.3. So we just wanted to show how our need is towards routine ANC EPI. And just to mention that we do not have a gap this year for routine ANC and EPI. For mass campaign, our strategic shift, just like everyone else, every program in here, we've made strategic changes to our scope based on our available funding. Our initial plan was to conduct our campaign with about $50 from procurement to implementation. However, following our strategic shift to prioritize, we've reduced our budget to about $34 million. So our key drivers for our cost reduction has been prioritization. Our scope has reduced, so we're looking at reduction from 115 districts to 81 districts in the high burden areas. We've also digitized our campaign. In the previous campaign, we did both paper and electronic gadgets, and this was added an additional cost to our budgets. I think because it was our first digitization and we were a bit holding back to see how do we back up our data. So we did collect data both electronic and paper-based. However, in this year's campaign, we're going purely digital. There will be no paper-based registers that will be printed. Our strategy has equally shifted from door-to-door that we did in the previous campaign to fixed point distribution. So that has also, we've made efficiencies on that component as well. And we've integrated the training approach. For the higher level trainings, we've shifted to virtual. And to the lower level trainings, we are doing the physical training. So we've made some savings on that as well. Next slide. In terms of resource sustainability and domestic mobilization, we've had commitment from domestic resources, especially towards routine ANC API. So we have, the government of Zambia is procuring ITNs and also doing last mile delivery to the health facilities. We do still need external funding, especially for mass campaigns. And we are yet to explore the private sector in terms of as an additional channel. So for the campaign this year, we're doing our campaign, like I earlier mentioned, in 7 high burden provinces, with one province where we're targeting only 1 district. So it's 81 out of 116 districts. So our prioritization is basically informed by surveillance and stratification data. And our key funders for this year's campaign include Global Fund, Against Malaria Foundation, and the Department of State through the Global Health Supply Chain. Our distribution timeline, we plan to do our actual distribution in September through to October. And we will have 2 types of nets, the DOAI and the PBO. Next slide. So this map is just to show our malaria score, how we arrived at which provinces we're going to target for the campaign. This malaria score is based on the incidence for all ages and prevalence data in under 5s. And as you can see, the darker shades, that's where we have the highest score, as somewhere in Northwestern and Waplo province. So the darker the shade, the higher the malaria score, the higher the burden. Next slide. This is just to show the scope, who's funding where. So the green, you see that the green part is the Global Fund provinces. That is where the Global Fund support is. And in terms of the ITNs, and the green, that is where we're taking the DOAI, being the high burden provinces. So we're taking the DOAI nets there. Is it yellow? The yellow parts, yeah. We'll have a mix. We'll have both PBO and DOAI nets. And the blue part will have PBO nets. So these are some of the moderate burden areas. So what then is our expected epidemiological impact? We expect to have high coverage in transmission data, so in high transmission strata. So we've come to realize that with the available funding, we need to get the highest epidemiological impact from there. And also, we want to have an improved impact per ITN distributed and reduce malaria incidence in prioritized districts. We also expect to have a sustained protection of the vulnerable population, that is the pregnant women and the under 5 children. Our take-home messages, this is our strategy for this year, and just to mention that this strategy reflects stratification and resource realism. We're working with the available resources, and we want to have the best impact with what we have. So mass campaigns will remain essential for restoring universal coverage, especially in the high burden areas, and routine platforms targeting the vulnerable populations will still be key. And we'll continue to do surveillance-driven deployment, which will accelerate the elimination trajectory. And lastly, protection is being concentrated where it yields highest epidemiological return with confirmed resources. So just to acknowledge the key players that have been part of our planning, please, if you're not there, we do acknowledge. Thank you.
Thanks so much, Katie. We will now have time for questions, and they'll be addressed by Katie and Fatima. So okay, so we will take the first three, and when we have time, we will take other questions. Yes, so 1, 2, okay, and then 3. So yes, 1, yeah, yes.
Hello. Hi there, Annie from Malaria Consortium here. Thank you for 2 really excellent presentations. My question is, in Zambia, you mentioned piloting and ambitions for community distribution. And I was just wondering if you could elaborate on what that approach looks like and the targets for that distribution as well, the target groups. Thank you so much for a great presentation.
Second, this side. There's a hand here. Yes.
Thank you. The name is Ateka from Kenya. The question I have is for Zambia. First of all, great presentation as well. You said that for the first time you've had domestic funding. I'd like to know like the mechanisms or rather the factors that you considered or rather the approach you used to be able to do that, because like we said, there have been a lot of domestic fatigue. So the fact that you've been able to do domestic funding is very impressive, and we'd like to use that as a benchmark.
All right. And then the third from Otubia. Yeah. You can use your microphone. Yeah.
Hi, good morning. Can I be heard? Hello, can I be heard?
Yeah.
Okay, good morning. My name is Otubia, NMEP Ghana. My question is to my big sister from Nigeria. You mentioned about institutionalizing durability monitoring. It will be interesting to hear your ideas or a bit more detail on how you intend to do that, and you think it's worthwhile in the midst of the current funding landscape we find ourselves. Thank you.
All right, thank you. So, Katie, please respond, and then you'll be followed by Fatima. Over.
Thank you very much for these questions. The first one, I just want to make sure I got it correctly. Community distribution piloting, how does it look like? Thank you. We've been trying to begin with, we do have the ITN guidelines, which includes almost all the key community continuous distribution channels. We've been trying to pilot community distribution, and what we're trying to explore, because in Zambia we do have community health workers that are doing ICCM. In addition to that, we do have the polyvalent community health worker as well that is not just doing one disease area, but doing different disease areas as well. So we're trying to work with those community health workers to deliver the nets to the household. So that strategy for community case management, ICCM, is the same strategy we might tap into to do the delivery of nets to the households, because they're already testing, they're already treating, so we can add one component to just ensure that they also deliver that net to a particular household. However, this might not basically not go across the country, but it might be targeted based on how community structures are and how best it's going to provide impact or to help sustain coverage within the communities. Thank you.
Thank you.
Maybe I answer the next one. I had two on domestic financing. Thank you very much. So with regards to domestic financing, for Zambia, we've had most of the domestic financing was going towards indoor residual spraying, especially with procurement of insecticides. However, we've scaled down on indoor residual spraying, and that has freed the budget somehow to also add an additional vector control commodity, which is ITNs. And not only ITNs, we are also, there's a budget line for vector control commodities that we're also looking at procuring entomological commodities and also larval source. So we are tapping into that, that funding. Thank you.
All right. Yes, Fatma.
Okay, thank you for the question. My sister from Ghana. Yeah, so for plans for durability monitoring, the plan is to use our institutions where we have established sentinel sites to build capacity and be able to track the nets that are distributed in Nigeria. We have a lot of data on net use and care, and we want to see how that translates to durability monitoring, the durability of the net across different regions in the country. We have had an extensive study done 2019, 2020 in partnership with Tropical Health, with a lot of interesting results about the durability of nets in different regions. So this can give guidance on how we can advise people to take better care of their nets, because that tends to be a factor in terms of durability of the net long term. So these are still at the planning stage, but we hope to implement within this year or next. Thank you.
Thank you, Fatima. We have about just 5 minutes more before we break for snack. Are there any hands? Yes. So, David. And then another one here. Yes, 2 questions before we break. Yeah.
Can you hear me? Good. Hi, both. David Gittleman, I'm part of the AMP core group, and a wonderful presentation. It's a very important presentation, actually. I wanted to ask a little bit about one of the themes of this week, that's integration. I noticed you had noted that in ITN and SMC integration as part of these efficiencies that you're looking at in Nigeria. Did want to know if you're experimenting to go beyond that as part of this whole strategy to look at efficiencies, vitamin A, immunizations, MDAs for NTDs and so forth. And I might have missed it for Zambia. I didn't see any notes on integration. Is that going to be considered in the future as part of this drive toward efficiency? Thank you very much, and great presentation.
Thanks, David. The second question, yeah, from that side, yes. As you can use your mic on the table. Yeah. Okay. All right.
Okay. Thank you, David, for your question. So, yeah, absolutely right. In Nigeria, we have had other integration activities beyond IT and SMC. We have integrated with vitamin A. We have done co-implementation, I would say, with immunization, because of the timing of the campaigns and team size and number of days of distribution. We couldn't co-deliver the tools, the nets and the immunizations at the same time. But however, things like SBC monitoring were integrated, so it was co-implementation. So the country is working better towards integrating more health interventions, working closely with the Campaign Effectiveness Initiative. This is one of the strong mandates of the Federal Ministry of Health to integrate different health interventions as much as possible to maximize resources. Thank you.
Thank you very much. Are we planning integration? Yes, we are. And like I earlier mentioned, we are coming to the end of our strategic plan. And the program has already started looking into the sub-national tailoring. And we will be having our interim review this year. So those are some of the cost efficiencies that we are also considering, and we're very open to see how best we can explore. So are we integrating? I can say yes. Thank you.
All right, thanks so much. Let's appreciate Katie and Fatima as they take their seats. And thanks everyone. We will take a break for, let's say we will return 11:10. 10 minutes after 11, we'll take tea and then coffee, and then we'll be back. Over. Thank you. Optimize operations within the chosen channels. And so to help us do this, we would want to look at lessons from 3 different countries, Ivory Coast, Sierra Leone, and Kenya. And so please, let's welcome Kofi Amani Serge from the NMCP Ivory Coast, and then Dr. Mark Abdul Falama, also from the NMCP Sierra Leone, and then Edith Ramaita from Kenya. Please take your seats, and then let's have the first presentation from Kofi.
Bonjour, mesdames et messieurs. Je suis Kofi Amani Serge. Je suis logisticien au programme national de lutte contre le paludisme en Côte d'Ivoire. J'ai l'insigne honneur de vous faire la présentation qui a pour titre la campagne mi-2024 en Côte d'Ivoire, leçons apprises, perspectives, post-évaluation logistique et optimisation des campagnes futures. Alors, notre présentation se présentera en deux mouvements autour des points suivants. Premièrement, nous présenterons un aperçu des fondamentaux de la campagne MILDA. Ensuite, nous vous présenterons quelques résultats et nous identifierons les défis auxquels on a pu faire face pour atteindre ces résultats. Et dans un second mouvement, nous parlerons de l'évaluation logistique de la campagne 2024, quels en ont été les principaux constats et les principales recommandations qui en sont sorties. Et pour finir, nous présenterons les perspectives pour les futures campagnes. Pour parler des fondamentaux de la campagne MIL 2024, nous disons que la campagne 2024 a été organisée dans 101 districts en Côte d'Ivoire, qui représentent à peu près 90% des districts sanitaires du pays. Et la campagne a été également une campagne de type stratifié, avec une utilisation des insecticides standards et de nouvelle génération. Ainsi, on a eu donc 24 districts sanitaires qui avaient des moustiquaires standards, 32 districts sanitaires qui avaient des moustiquaires IG2 et 58 districts qui avaient des moustiquaires PBO. La campagne était également une campagne digitalisée, donc avec 16 districts sanitaires totalement digitalisés, c'est-à-dire que la collecte des données s'est faite à partir au niveau des ménages par les volontaires sur des tablettes, et dans 85 districts sanitaires, la consolidation s'est faite au niveau du district sanitaire. Cette campagne aussi, on a utilisé la stratégie de distribution selon une MILDA pour 2 personnes. Et autre particularité, c'est la distribution communautaire dans 5 gros villages. Donc, dans 5 gros villages qu'on a identifiés sur toute l'étendue du territoire, dans ces villages-là, ce sont les villages eux-mêmes qui ont procédé au dénombrement et également qui ont fait la distribution aux récipiendaires. Alors, vous verrez sur les cartes qui sont là, la première carte, donc la couleur plus claire, ce sont les MILDA standards, donc on voit plus au nord du pays. Et la couleur verte, ce sont les MILDA IG2, donc à l'ouest, au centre, et puis au nord-est et au sud-est. Et la couleur jaune, ce sont les MILDA PBO, donc vous voyez que les MILDA PBO occupent une plus grande partie dans le pays. Et la deuxième carte, ce sont les districts qui ont reçu là où on a fait la digitalisation. Quels ont été donc les résultats de cette campagne? Nous avons pu dénombrer 29 millions, un peu plus de 29 300 000 personnes contre 24 700 000 personnes planifiées, soit un taux d'atteinte de 118%. Nous avons distribué plus de 14 210 000 moustiquaires contre 14 800 000 qui étaient disponibles, soit une performance de couverture de 96%. Et dans la population, et nous avons obtenu aussi 81,3% du taux d'utilisation. Et donc après la campagne, nous avons 6 à 7 mois, un peu plus de 9 mois après la campagne, nous avons fait une évaluation post-campagne. Et cette évaluation a permis donc d'avoir un taux de 81,3% du taux d'utilisation, dépassant ainsi la cible recommandée par l'OMS. Et vous verrez donc sur la carte, on voit les différents districts dans lesquels on peut observer la couleur bleue. Les couleurs bleues, c'est les districts dans lesquels nous n'avons pas fait la campagne parce que ces districts avaient fait l'objet déjà d'une mini-campagne. Et puis au niveau d'Abidjan, la couleur bleu foncé, c'est au niveau d'Abidjan parce que la zone d'Abidjan, les districts sanitaires d'Abidjan, il n'y a pas eu de campagne. Dans la couleur verte jusqu'aux couleurs jaune, on a eu donc des performances qui sont allées de 80% jusqu'à 95% de performances de couverture. S'il est vrai qu'on a pu obtenir des résultats satisfaisants, il est tout aussi vrai qu'il y a eu des défis auxquels on a été confrontés. Et donc, on a dû mettre en place, adopter une capacité de résilience qui nous a permis donc de pouvoir avoir ces résultats-là. Et en termes de défis, ce sont des défis d'ordre logistique. Nous avons noté donc une rétention des moustiquaires au niveau des différents ports d'Abidjan. Il faut préciser ici que les ports de San Pedro et d'Abidjan sont les 2 ports d'entrée du pays, mais la Côte d'Ivoire est le premier pays producteur de cacao et au cours de l'année, il y a 2 périodes pendant lesquelles il y a une forte activité de cacao. Et ces activités-là impactent impacte la disponibilité en termes d'occupation d'espace des conteneurs. Donc, il faut une planification efficace pour que les conteneurs qui arrivent sur les ports puissent véritablement être, je veux dire, que les opérations portuaires puissent se faire pour que ces conteneurs-là puissent sortir. Et c'est ce qui a manqué un peu. Donc, au niveau, par exemple, du port de San Pedro, il y a des moustiquaires qui sont restés dans ces ports-là, qui n'ont pas pu sortir au moment où on en avait besoin. Donc, il a fallu que le directeur coordonnateur puisse donc diligenter un déplacement de la chef du service gaz pour qu'elle puisse aller jusqu'à San Pedro afin de rencontrer les autorités portuaires et de pouvoir libérer ces moustiquaires-là. Nous avons eu aussi le défi concernant l'insuffisance des capacités de stockage dans les districts. Alors, nous avons fait une évaluation des capacités logistiques, une évaluation des capacités de stockage dans les districts. On a fait cette évaluation-là 6 à 7 mois avant la date planifiée de la distribution, autour de novembre 2023. Cette évaluation a relevé donc un besoin de 170 espaces de stockage à réhabiliter et de 115 conteneurs fin de vie à acquérir. Il faut noter qu'en Côte d'Ivoire, depuis plus de 5 éditions que nous faisons, la particularité, c'est que nous utilisons les conteneurs comme espace de stockage de prédilection des moustiquaires. Donc, depuis 2011 qu'on a commencé les campagnes, il y a eu des acquisitions de conteneurs qui ont servi de stockage pour les moustiquaires. Et au cours donc de cette année, quand on a identifié le besoin, les travaux qui devaient être faits sur ces conteneurs n'ont pas été faits à temps. Ces travaux n'ont pas été faits à temps, donc du coup, la date planifiée pour la distribution n'a pas pu être justement réalisée. Et cela a été un réel problème, mais grâce à l'organisation, grâce à la résilience donc de la direction de coordination avec l'équipe de campagne, on a pu prendre des mesures de mitigation, notamment l'identification des écoles, puisqu'on était pratiquement dans la période des vacances. Donc les écoles ont été utilisées comme espace de stockage avec un renforcement de la sécurité, avec la mise en place des gardiens de jour comme de nuit pour surveiller les moustiquaires, et cela donc a permis de pouvoir faire la distribution. Nous avons eu aussi des problèmes concernant la production des outils, la reproduction des outils. On a eu des soucis dans il y a eu donc une lenteur et une insuffisance dans le processus de reproduction des outils. Parce que il y avait une innovation, c'était les cartes avec code QR. Et dans le pays, il n'y avait pas beaucoup de structures qui étaient capables de produire, donc cette carte avec le code QR. Et on a pu relever donc ce défi également. Il y a eu aussi une quantité planifiée qui était inférieure aux besoins pour le dénombrement. Dernièrement, comme défi, nous avons noté donc les moustiquaires qui n'étaient pas positionnés à temps dans les districts, voilà, et les moustiquaires étaient également positionnés en quantité insuffisante. Vous verrez que ces différents défis sont liés les uns les autres. Nous venons à présent à l'évaluation logistique. Je le disais tout à l'heure, on a pu avoir des résultats, on a eu une très bonne capacité de résilience, mais au niveau du programme national de lutte contre le paludisme, avec nos partenaires, nous nous sommes dit, c'est vrai qu'on a eu de bons résultats, mais on ne peut pas dormir sur nos lauriers. Il est bon donc de faire une réflexion approfondie pour chercher à savoir qu'est-ce qui s'est passé exactement, les problèmes que nous avons rencontrés, est-ce que ces problèmes-là, quels ont été les fondements de ces problèmes-là, de sorte à ce que pour les prochaines campagnes, on ne puisse pas les avoir. Donc, c'est ce qui a suscité donc l'initiative de l'évaluation logistique. Pour nous, il était question de pouvoir mettre des mots MOT sur les mots MAUX que nous avons pu avoir pour que justement on puisse les adresser et en sortir des recommandations. Ainsi donc, des objectifs et de l'évaluation étaient d'examiner la documentation de la campagne précédente. Donc tous les documents ont été donc passés en revue, notamment les documents normatifs, la macro-planification, la micro-planification, les différents plans logistiques, y compris aussi les rapports existants. Il y a eu donc l'identification des points clés à discuter sur la chaîne d'approvisionnement pour pouvoir mieux questionner la chaîne d'approvisionnement. Il y a eu également la collecte des informations au niveau du district. Donc l'équipe qui a mené l'évaluation est descendue jusque dans les districts pour pouvoir capter le retour au niveau même des districts et la proposition des recommandations. La méthodologie utilisée pour le choix des districts sanitaires, le choix était basé sur une approche raisonnée qui combinait plusieurs critères, notamment la performance de distribution, les enjeux logistiques observés, la représentativité géographique. Il y a également la collecte des données qui s'est appuyée sur une analyse, une approche qualitative descriptive et reposant sur la réalisation d'entretiens individuels. Donc, à partir d'entretiens individuels sur les personnes clés, les informateurs clés du système de la chaîne d'approvisionnement ont pu être contactés pour avoir ce retour-là. Donc, et la dernière étape, c'était la présentation des résultats pour en sortir les forces, les faiblesses et les recommandations. Quelles sont les difficultés majeures qu'on a pu constater au terme de cette évaluation? Donc, on a relevé une coordination logistique qui était perfectible. On a relevé des infrastructures de stockage inadaptées, inadéquates au niveau des strictes de formation sanitaire. On a relevé aussi un retard dans la sélection des transporteurs. On a relevé une sélection et la gestion des transporteurs sans l'implication active de l'équipe cadre du district et puis une sous-traitance aussi mal maîtrisée. Qu'est-ce qui s'est passé? Alors, concernant le transport, le partenaire logistique avec lequel nous travaillons avait la responsabilité d'identifier les transporteurs qui devaient amener les moustiquaires du niveau district jusqu'au site de distribution. Et pour pouvoir le faire, il s'est attaché les services de transporteurs. Mais il s'est trouvé que le mécanisme de sélection de ces transporteurs qui a été adopté, c'était un appel d'offres national. Et on s'est appuyé sur des entreprises qui devraient avoir des documents, c'est-à-dire la déclaration fiscale d'entreprise. Il faut que ces entreprises-là soient régulièrement constituées. Pourtant, au niveau local, les entreprises de transport n'ont pas leurs documents. Ce qui fait que ce sont des entreprises qui n'appartiennent pas aux circonscriptions réelles, qui ont postulé et qui ont remporté le marché. Donc, le monsieur, il se trouve à Abidjan et puis il remporte un marché au niveau de San Pedro et donc il gère à distance, il est obligé de travailler avec des sous-traitants locaux. Et il s'est trouvé que les sous-traitants, eux-mêmes qui ont postulé et qui n'ont pas remporté, ils se sont mis ensemble et ils ont fait barrière. Ils ont fait barrière et ça crée des difficultés. Donc, ça a été vraiment très compliqué. On a noté aussi une rupture des cahiers de dénombrement à cause du défaut d'estimation de population. Le nombre de cahiers de dénombrement que nous avons pris en cours d'activité, ces cahiers-là se sont retrouvés insuffisants. Donc, il fallait vraiment user de reproduction au fur et à mesure pour alimenter, pour ravitailler le pays. Il y a eu aussi les gestionnaires de stocks qui sont un personnel très important pendant la distribution. Bon, on a noté qu'ils n'étaient pas, leurs compétences n'étaient pas véritablement avérées. On a noté une absence de procédure écrite pour le retour des moustiquaires et une absence de plan de gestion des déchets. Donc, on voit bien que toutes ces difficultés montrent l'écart entre les normes attendues et puis les pratiques qui ont été observées. Et ces écarts-là appellent à des recommandations pour pouvoir optimiser les prochaines campagnes. Au titre des recommandations, donc, nous avons classifié ces recommandations-là. Concernant la gouvernance et la coordination, il a été recommandé de recruter un prestataire logistique formellement avec une définition claire de ses rôles et responsabilités, avec une identification des indicateurs de logistique, avec aussi l'obligation de transfert, de compétences. On a noté aussi la mise en place d'un dispositif de suivi des activités du prestataire. Donc, ce prestataire qui sera recruté, va faire l'objet d'un suivi pas à pas. Chaque activité qu'il aura à faire, il va travailler en connivence avec le programme national de lutte contre le paludisme. Et bien entendu, une sorte de cluster logistique sera mis en place afin que tous les acteurs logistiques qui interviennent puissent se retrouver et suivre l'évolution des activités au fur et à mesure, ce qui a manqué à un certain moment. Et durant les étapes préparatoires, on fera le suivi des commandes et anticiper les risques. Tout à l'heure, je vous ai parlé des risques au niveau du port. Donc, c'est des choses qu'il faut anticiper très tôt. On connaît la période de traite de cacao. Donc, par rapport à cela, on peut planifier l'arrivée des moustiquaires de telle sorte que cette arrivée-là puisse être progressive. L'arrivée des moustiquaires puisse être progressive pour ne pas qu'on ait un engorgement des moustiquaires au niveau du port. On a donc noté aussi d'analyser les rapports d'évaluation des capacités de stockage. Donc, quand on finit de faire l'évaluation des capacités de stockage, il faut analyser ces documents-là pour en sortir de bonnes résolutions.
Kofi, you have 2 more minutes.
OK. Donc, concernant la macro-planification, il a été recommandé donc d'institutionnaliser la triangulation systématique des données notamment les données de recensement général de la population, les données de micro-planification, les données des différentes campagnes. Donc, il faut faire une triangulation pour que les données qui en sortent puissent être plus proches de la réalité. Il a été demandé aussi de développer des procédures opérationnelles qui sont liées donc à cette triangulation-là. La recommandation aussi a relevé l'élaboration et la mise à jour régulière d'un plan d'analyse et de mitigation des risques. Donc actuellement, nous sommes en train de faire le plan d'action opérationnel et on a pris en compte ces recommandations-là. Donc un plan de gestion des risques est en train d'être fait. Il a été recommandé aussi d'élaborer un chronogramme qui prend en compte toutes les étapes de la campagne et d'identifier les jalons critiques et de partager ce chronogramme-là. Donc déjà, ce chronogramme a été élaboré et il est en cours de partage. Sous le leadership du PNLP, il a été recommandé aussi d'assurer la micro-planification, de s'assurer que la micro-planification soit finalisée et validée afin de configurer un système digitalisé. Il a été recommandé aussi d'ajuster les stocks à partir des quantités de dénombrement, à partir des données validées du dénombrement. Voilà. Donc, la logistique inverse, on a parlé aussi de l'entreposage. Donc, organiser des missions d'évaluation des capacités de stockage, j'en ai déjà parlé. Assurer la réhabilitation. Donc, une fois qu'on a identifié les espaces à réhabiliter, il faut donc le faire. Il faut passer à cette réhabilitation-là. Donc, nous avons retenu ces leçons-là. Mettre en place aussi un plan de gestion des risques des transports. Voilà. Formaliser des procédures de logistique inverse et puis renforcer notre système de formation, voilà, assurer un suivi post-formation, former spécifiquement les différents acteurs avec des techniques de formation mises à jour, élaborer un plan de gestion des déchets. Et pour finir, donc nous avons identifié ces différentes perspectives-là afin que les prochaines campagnes puissent être réussies. Il faut justement faire, dans la macro-planification, il faut procéder à la triangulation. Donc ça a été fait pour la campagne 2027 et c'est ce qui sera fait pour les prochaines campagnes. Et pour les prochaines campagnes, le PNLP a décidé donc de recruter ce prestataire logistique qui va travailler pendant 3 ans avec nous. La procédure sur la logistique inverse, elles sont en cours d'élaboration pour la prochaine campagne. Je rappelle que nous avons la campagne en avril 2027. Il faut former spécifiquement les gestionnaires de stock avant l'arrivée des moustiquaires, au moins 1 semaine avant cette arrivée, et puis prévoir les espaces de stockage plus adaptés. Donc nous avons réfléchi, nous allons utiliser des entrepôts qui respectent donc les normes comme recommandé par cet assistant technique. Je voudrais au passage dire merci à l'AMP qui nous a appuyés avec l'appui financier du Fonds mondial, qui nous a appuyés donc dans cette évaluation logistique, qui nous a permis de nous regarder nous-mêmes et de comprendre les problèmes et de prendre de bonnes résolutions. Je vous remercie.
Thanks so much, Kofi. You may take your seat. We will now pick lessons from Sierra Leone, Dr. Falama.
Hello, good morning. I'm Dr. Abdelmak Falama presenting on behalf of the National Malaria Control Program, Sierra Leone. Today I'm happy to share with you evidence from the school-based distribution, from the scale-up to pilot to a scale-up campaign, looking at optimizing ITN distribution channels. Mass campaign remains the primary channel to establish universal ITN access. However, coverage declines between campaigns. ANC and EPI, these are the routine channels that we also distribute ITNs. We target vulnerable population, pregnant women, and our children. Yet there is limited ITN access in the population. So therefore, continuous distribution, the school-based distribution serves as a channel where we sustain coverage in between campaigns. The graph describes a typical pattern of ITN mass campaign how coverage declines over time. It peaks immediately after campaign and declines over time. That's an illustration from one of the pilot districts for SBD. So this graph demonstrates the need for continuous distribution to sustain the gaps in between campaigns. So school-based distribution does not replace mass campaign, rather it complements the gaps that, it's observed in between campaigns. So we adopted the school-based distribution based on clear criteria. The large population, its target large population, epidemiologic importance, existing infrastructure, it's cost-effective, and it's scalable. So schools provide high enrollment rates, so we're able to reach large population, regular contact with children, and it's a platform for distribution of ITNs, and also health education. It's a direct point where we reach household through the pupils. So we take into cognizance the decision for us to deploy school-based distribution based on the SNT. We looked at the ITN access, existing vector control intervention, and the malaria burdens. So we are able to adopt the school-based distribution strategy as a continuous distribution channel. So the infographic just shows how nets are moved from the central region to the district warehouse and onto the PHUs. So the PHUs staffs will, alongside with the school teachers, will distribute the nets in the schools. We also integrate behavioral change communication messaging. We utilize a digital tool, a local-based digital tool, ICF Collect. So we have real-time monitoring and dashboards. So in 2023, we implement the pilots in Kono district. We targeted 531 schools in classes 1, 3, and 5. We are able to distribute 88,605 PBO ITNs and reached these pupils with strong behavioral change messaging on net use and care. So we attain a coverage of 96.8. This demonstrates operational feasibility and acceptance of school-based distribution. So to assess impact, we further conducted household survey, wherein we compare household with children with eligible household with eligible children for SBD and those without. The findings show significant improvements in all the indicators: household ownership, ITN access, and ITN use in household with eligible children for SBD. So these paper was published so we can further search and get more insight into the findings. So based on the success of the pilot, we expanded to 2 districts. We targeted 1,173 schools in classes 1, 2, 3, 4, and 5. So we are able to reach 1,161 schools with over 200,000 pupils receiving ITN, 93% coverage, and we're able to protect nearly 500,000 population. So these findings demonstrate school-based distribution does not only increase coverage, but also, improve protection to households. So we further analyzed the school-based distribution in the 2 districts, looking at the contributions of the intervention to ITN access. Mass ITN campaign is the dominant contributor to ITN access in both districts. The routine ANC and EPI provides smaller but steady contribution to the access, and it's also targeted vulnerable population. So the school-based distribution provides the intermediate gap between campaigns and as well as the gaps observed from the routine channels. So for us to have a successful SBD distribution campaign, of course, coordination is critical. We are able to strengthen coordination and collaboration between the education and the health sector. The use of digital tool, we use the ICF Collect that shows real-time monitoring and GPS tracking. And we are also able to integrate SBCC messaging into the campaign. We are able to reach the pupils, the teachers, and as well as the parents within this implementation. So lessons learned, of course, strong collaboration. Coordination is critical. We need to bring on board the health and the education sector. We need a minimum of 12 weeks for planning, adequate planning, so that we'll be able to, validate the enrollments, because every year we do have the school census, but these numbers need to be validated early so that we'll be able to distribute the adequate amount of nets. We also align our implementation calendar to the school calendar. The use of digital tool for monitoring and real-time implementation also enables smooth implementation. Of course, targeted SBCC, we're able to reach the pupils, teachers, and also the households. We also rechannel leftover nets for routine ANC and EPI. We implemented waste management as well, wherein we recycle plastic waste. So recommendation, of course, we recommend to incorporate and adopt school-based distribution as part of continuous distribution. Also integrate it into the national monitoring system, wherein we need to strengthen financing and logistics, maintain good collaboration between health and education sector, enhance communication through integrating SBCC, conduct long-term impact evaluation so as we're able to know the effects on the malaria burden by SBC the distribution. So in conclusion, multi-channel delivery is required for universal coverage. SBD is an effective continuous distribution channel, not to replace other channels. SBD serves by stabilizing coverage between campaigns, improve household ownership and access, also supports replacement of damaged nets, and it's essential in sustaining malaria prevention gains. Thank you.
All right. Thank you very much, Dr. Falama, for the presentation. Edith, yes, over to you.
Morning, everyone. Good morning. I believe the group that is summarizing everything for everyone now that we are the last two. So I'm going to do a presentation on channels of delivery, but I'd like to just do an overall overview to just see how we arrived there as a country. I feel like the steps that we took, basically each step led to where we are at the moment, and so it's important to just take an overview of where we started. So basically this is the country's vector map, and I'm an entomologist, so everything I'm going to speak, I'm going to tailor it to the mosquito. So this is the vector map for the country where we actually map, and for us, every discussion we were doing here, I look at this as this is the enemy we are fighting. And by understanding this is how we know how to direct these interventions. By you understanding the mosquito, each intervention you're putting in place to interrupt transmission, you have to direct it based on the mosquito itself. Meaning, for you to put an ITN in place, you have to have proven that your vector is indoor biting. For IRS, it has to be an indoor resting mosquito, and if you're doing indoor interventions and you have a gap with outdoor transmission, then it means you need to address that. So by looking at this, I look at the basis of every where we base our interventions, and in choosing the type of insecticide-based tool, then you have to understand your insecticide profiles for the vectors that are transmitting. So this is the vector map for the country, and basically we collect this data to just guide us on which interventions will work where, and so that we put the appropriate tool in the right place. Sorry, I'm not good at these things, so working. And this is the stratification, malaria stratification within the country. If you've seen our map before, I know you can tell that this has been changing over time, and it's really from no transmission to very high burden areas, and even within specific, we have 47 counties, and within those specific counties, even the dynamics change lower. So the question is, how are we utilizing this as a country to make decisions? Because previously we used to look at this and we would apply blanket interventions based on the burden profiles. But then now with the resources that are available, it means we need to look beyond the burden at the county level and stratify it lower. And this is basically the intervention mix based on the burden stratification. You can see some are cross-cutting, like case management, surveillance, and as you can see, the others are put according to the risk stratification. But then again, that is based on the data components that we are also collecting, as I had indicated, and also resources that are available. And then we have a strategic plan running from 2023 to 2027, and those are the key objectives for those areas. We'll narrow down to objective 1, which is basically the vector control intervention, and then we narrow down to the ITN. So for those are the key interventions with basically as a program, all these objectives have to work together for us to be able to achieve the elimination goals. So our objective 1 is where we now have the vector control interventions, where we have ITNs, IRS, and LSM as the interventions in place, ILLNs, ITNs, and IRS as the co-intervention, LSM as supplementary. We introduce another important strategy, which is adopt new appropriate vector control interventions. And this is us choosing to actually utilize the data that is being generated within the country with the changing dynamics. And for that, one of the tools we adopted is spatial repellents for the country, where we generated really good data that showed impact. And so we adopted that as one of the research, the data that came out of research that showed impact, and so we adopted it. And we included this in the strategy so that we utilize our own in-country data. The other part is we've strengthened a lot of vector surveillance data. We digitized the entomological data for the country to really help and guide us in making decisions in selecting the tools that will work in the specific setups. Not sure it's skipping or... So how are we utilizing data to make decisions? So this is our Kenya Health Information System platform. It's basically the reported cases from our facilities being reported from the health facility level to the national level, and we're able to visualize this data. But I think we can all agree that we've been reporting how we have really multiple data sets, but then this is our health information system, and then also there has to be really a lot to do in terms of the quality of data that goes into this, because if we have gap or if we have issues with the quality of data that is going here, this is the data we're actually utilizing to make the decision. And then I had said we had digitized the entomological data, and this is the database. It's the DHIS2 database, and basically this is where we reference, we are able to know the vector species, confirm transmission in the different area, confirm, also do check on the resistance profiles of the vectors, and these also, as you can see, the indicators we key in, which is actually important in terms of the quality of the data you collect, is dependent on the indicators that you fed in. So we know we need to direct interventions by knowing the vectors themselves, so we have to know where the transmission is happening to know which tool to put in place, and also determine the effectivity or the susceptibility profiles of those vectors to know the tools that will be appropriate for that setup. And so we utilize those data sets to make decisions for putting down the vector control tools. Like for ITNs, and the data you're seeing on the right is actually the one we have the campaign that is coming up 2026-2027, and this is actually a snapshot of the data sets that we use in the micro planning to decide on where we are going to put the nets in this coming campaign. So we stratified, we allocate ITNs based on the malaria risk stratification. As you had seen our map, you'll see the very high burden area, high burden, moderate to low transmission. But then how did we use that data or the AP data that is coming in to stratify lower into those profiles? So we ranked, as you can see the columns, you see there we have the county, then you have the sub-county within those counties. So you rank the very high burden, and then you go lower to the sub-county level, and we used the data for 2021 up to 2025 June, and we did the average burden rate for those sub-counties within those counties, and that's how we ranked from the highest average burden rate to the lowest average burden rate. And then now that is how you place, we prioritize placing interventions with the resources that were available. The other key factor that played in is the resistance data, because we had to choose the type of ITN to put in place, and you know that has the cost implication. And so if we were, for example, to put all pyrethroid, you'll probably cover more sub-counties within the counties because of the cost. But because of the insecticide resistance profile, which you can see, we have widespread pyrethroid resistance with multiple mechanisms of resistance, and that is where you would see from in our country we chose to go to put pyrethroid nets where we have no pyrethroid resistance, do dual AI nets where we had pyrethroid resistance. We previously had PBO nets, but as you can see, we have multiple mechanisms of resistance, and for that we determined that the tool that will be more effective will be the dual active. So with that, we were able to now stratify and then rank all the sub-counties within the counties, and then place the interventions, which is either based on the resistance profile, which type of net, and then applied the resources that were available. And for that, we can also, we were able to calculate even the existing gaps depending on how many, on the sub-counties that we need to cover. So what are the ITN distribution channels in the country? We've been doing mass campaign for a long period as a country, and I have a table that just shows the history in the next slide. So we've conducted that every 3 years in fixed distribution post, and this targeted all households in those selected areas. Then we've had routine ITN distribution, but for a long time this has just been covering and I think I've heard this from various countries, been covering the pregnant woman and the children under 1, and that is what we have also been doing as a country. And because of that, we will be able to achieve at a mass campaign high coverage, then maintain protection to the pregnant woman and the under 1 over the 3-year period, which approximately was just covering around 6.5 of the population. But then we have attrition of the net dropping over the 3-year period to at about 13% of the rest of the population. So the question as a country is, we knew there was still a gap in terms of within the 3-year period, if we have attrition, then we are not maintaining the coverage that we are achieving at a mass campaign. And so that is one of the issues we wanted to address, and so we started working on a community continuous net distribution, which was within the strategy, but we have not been implementing using that channel. So this is the country historical overview. A campaign in 2006 was a phased campaign with measles, and then we had the next campaign, which was fully a phased campaign, and then every 3 years we did that. And then the change with the country was in 2023-2024 campaign, where we actually had a fully digitized campaign. I'm not sure why I have to do this 3 times for it to move. So we had a fully digitized campaign end to end, meaning we did everything within the system and did away with any paperwork. So the campaign basically registered households. We created a platform where we use USSD codes. So we registered households and then we distributed using that, and everybody who worked within the system for all the activities, all the events, they were all conducted within the system. And even the payroll was generated within the system. And the USSD code was the one that being used, and therefore we needed network let's say, I don't know what to call the network. We used Safaricom at that point, but of course we had challenges with the area where we did not have good network coverage, and for that we had an offline system to address that, where you will do the registration and then you do the upload afterwards. The other thing about this is we utilized the phone. The phones, you could utilize your normal phone or any other even smaller phone because it was a USSD code, and then we did our messaging through the same phone, both to the anyone who worked within the activity to confirm that you've taken part in the activity, and also to the households during registration to confirm registration, and also to confirm that you've received the net. This was a game changer because we realized that by digitizing this, we were able to actually track the net to the actual recipients. And with the next campaign that is coming, we had to make some changes based on the data that we got, because as you can see, we had a very good coverage of population covered at 94, household covered at 93. And for this, we are able to we have a reference point of this data set existing, meaning we can still have this household for the next campaign existing. And then we could also tell what the gaps that were there that we needed to address from this campaign. And for this now, the question was, what other strategic adjustments do we need to make as a country? So the funding reductions is affecting everybody. So in the next campaign, we realized that there needed to be some shift, and one of them I've mentioned, we stratified lower to the sub-county level instead of applying ITNs at the county level. And then we realized that we needed to do away with any duplication that is existing. So in the cutting of funds, one of the things we realized is the household. As I said, we already have the household population within Digima that we used in the previous campaign, but then we realized there was a parallel platform that is achieving a naturally registration process of household, and that is within the electronic community health information system. And so we looked into that and we realized, how can we integrate this system? If we already have a system existing that is doing household registration, updating household population, how can we have this data feeding into the platform that we're already using? And instead of doing household registration and spending a lot at a campaign, we can already have this data set. And so we started an integration process last year when we were doing our macro planning for the next campaign. And we integrated ICHIS into Digimal, and the results you're seeing below there is actually us piloting that, the system, and see what we can achieve. You can see we did not achieve, the results did not really achieve the targets. And so we determined the gaps that existed, and for that, key challenges that were there was the incompleteness of data. As I said, the quality of the data utilized really matters. So we were integrating a system that was doing household registration, but how much data we received from that was dependent on how much coverage they've had in the entire place. Have they been able to reach all the households? And because we had a reference point in terms of the previous campaign in the population that we registered, we could reference that against our census data and see what the gaps were. So that is one of the challenges. And then the other challenges is for the coverage they've had, what is the completeness of the data within those households? Have they completed a whole household? We all know to be able to give ITNs to those population, you need to determine that household size to quantify the ITNs. So those were the gaps that we found, and you can see the data there. And I would say this is a progress, ongoing progress for the country, where we need to strengthen the electronic community health information system. And one of the challenges that come with that is that it's being hosted by a whole entire different health division. So you have to work with them to actually ensure that they're keying in or they're achieving all the data sets that you need, so that you can be able to utilize the data to serve the population during a campaign distribution. So that's one of the changes in the country in the upcoming campaign. And then
Edith, 1 minute more. Yep.
Oh my. And I'm just reaching the interesting part. So there is the community channel, the routine distribution. As I said, for the country, the one that has been working is for the pregnant woman under 1, covering about 6% of the population and leaving out about 13, and there is that attrition coverage over the 3-year period. So 2 scenarios being considered, and this is work in progress for the country. 2 scenarios considered: having a continuous distribution between mass campaigns, meaning you do a mass campaign and then yearly you do the replenishment of ITNs. And then this could be actually, when you're doing that, you can start with some counties with mass campaign, some taking part in continuous, and then you learn lessons and then you move with it as you phase out probably the campaign over the period of time. While there is the scenario where you fully go into full continuous distribution to pregnant women through MCH and then have the community channel. So justification for that: high cost for mass campaigns, ITN coverage all year round, sustained through leveraging existing health system. As I say, this is anchored in the electronic community health system, where we already have our community health promoters going to households and doing the household services at that household level, and they can continuously update the households. So how did we, when we were inputting this into ICHIS, what were some of the workflows that existed, meaning we had to take the CHPs should be able to do household assessment, update household demographics, as well as assess the ITN conditions within the households. And with that, we were able, when they key in data, they will be able to see the ITN tasks at within the system at the health facility, and we could be able to issue nets and link facility to replenish. So what was happening for the household assessment, the CHP will update the household size, update household members, determine number of ITNs, do a physical count and confirm ITNs, and with that you can be able to determine whether they're sufficient or not sufficient, and then identify the pregnant woman under one, and this is to avoid duplication because they were utilizing the other channel within the MCH to pick the net, and so you will refer them and strengthen that arm too for them to pick the net while you're determining the ITN coverage within the rest of the household population. And then the CHP will also be trained to do ITN condition assessment. I know mostly after a campaign, we like distributing the nets, and then we'll do the durability monitoring of the net over the period of the time and collect data and determine the periodicity for campaigns based on the durability assessments. But then for continuous community channel, how do we assess the physical attrition of a net at a household? And so we inputted within the system and train a CHP how to be able to assess using the WHO standard to assess the physical attrition of that net by counting the number of holes, depending on the 4 different sizes that we have. And then we put within the system for it to be able to calculate the proportional hole index of that net and determine whether that net is in good condition or is a net that can be repaired or is a net that required replacement. And then with that, if the CHP updates the households and counts the net, the system can be able to calculate the sufficiency of that within the households by assessing the ITN conditions and determining those that are not in good condition. Then again, you can be able to determine how many nets that are required to be replenished in that household. And with the system taking all that into account, including determining the pregnant and under one within the household, the system could generate an e-voucher for ITN issuance to ensure there is ITN coverage within. That was meaning 1 ITN per every 2 people within that household. And that way you're able to sustain that coverage. And so, as I said, the e-voucher is generated automatically if there is insufficient ITNs based on household size, or if the net has a PHI greater than 643, or it's a net that the system determines that it's not serviceable. Then it excluded for the MCH issued ITNs to avoid duplication, and then that triggered a task notification to the community health assistant at the facility so that if the household member comes, they're able to visualize them and issue them net at the link facility. And then there was an SMS or notification to the household member on the location they're supposed to go and pick their net, which was mainly the link facility nearer to them. And then the ITN issuance, ITNs will be supplied and tracked at the facility. The community health assistant orders for ITNs within the system. Of course, you have to have the commodity to be able to issue within the system. And then household members were verified using ID, and the pregnant woman and under one were serviced by the MCH clinics, and then the system sends the confirmation message upon ITN receipt by the household member. So we literally worked through this and input this into the system, and we piloted this, and of course the gaps looked similar to the one that was within the campaign. And I think that's basically, sorry, I'm going to someone else's discussion. Sorry. And then the other opportunity we had is that the CHP, by visiting the households, was able to provide household level education by doing proper ITN use and care, repair. They were actually to teach how to repair a net that the system determined repairable, and then importance of timely replacement of those nets. Also, that's basically the structure we are working on within a campaign, how to integrate system and use existing data rather than do a repeat of household registration in a campaign. We use existing or introduce a community channel which we can either phase it out or go fully into it and utilize the existing systems. And so, as I said, it's still progress as we continue as a country. And I think that's the end of my presentation. Apologies.
Thank you very much. I just didn't have the moral right to stop Edith from presenting. So that was very good. Thanks, Edith, and thanks to the three presenters who are open for 3 questions in the interest of time. So I'll take 1 at the back, 2, and 3. Yes. Very quick questions. Over.
Ma question va à la Côte d'Ivoire. À Côte d'Ivoire, vous avez parlé de la logistique inverse plusieurs fois. Ma première question est de savoir si ça signifie que vous voulez récupérer les anciennes moustiquaires pendant que vous en distribuez les nouvelles. Si tel est le cas, est-ce que vous allez quand même distribuer à ceux des ménages qui vont refuser de remettre les anciennes moustiquaires? Parce que nous avons mené une étude qui a montré que jusqu'à 80% pouvaient remettre les moustiquaires, mais donc il y a 20% qui pourraient ne pas remettre. Le deuxième volet, c'est si vous récupérez, c'est pour mieux gérer les déchets. C'est quoi les approches aujourd'hui en Côte d'Ivoire que vous comptez utiliser pour gérer justement ces anciennes moustiquaires que vous allez récupérer? Merci.
Thank you. This side. The second question. Okay, let's take your question here.
Thank you. My name is Taka from Kenya. My question goes to Edith Ramaita. First of all, great presentation, very informative. From your expert perspective, do you see new malaria control interventions like the spatial repellents replacing current methods such as IRS, or are they more likely to be integrated alongside them?
All right, so please proceed with answering.
Merci beaucoup. La question concerne la Côte d'Ivoire. La question concerne est-ce que cela signifie récupérer les anciennes moustiquaires? Vous avez parlé de la logistique inverse. Bien, la logistique inverse, dans notre sens, la logistique inverse, c'est le processus qui permet justement de pouvoir repartir, d'abord avoir un point, un point par rapport aux moustiquaires qui ont été donnés, puisque là, dans notre cas, ce sont les moustiquaires. Donc, les moustiquaires qui arrivent, on fait la livraison dans les ménages. Après, les stocks restants, est-ce qu'on a un point sur les stocks restants? Ensuite, les stocks qui vont rester, est-ce que ces stocks-là reviennent au niveau des stocks primaires? Oui, non, c'est cela la logistique inverse dans notre sens, dans un premier temps. Maintenant, vous avez fait une ouverture sur la récupération des anciennes moustiquaires. Bon, pour l'instant, ce n'est pas cela que nous avons, c'est pas cela que nous avons envisagé. Mais sinon, effectivement, nous avons un plan de gestion des déchets qui sera annexé au plan d'action opérationnel au cours de la prochaine campagne. Et ce plan de gestion des déchets prend plutôt en compte la capacité de pouvoir récupérer les moustiquaires qui auront, les déchets des moustiquaires qui vont être créés au cours de la distribution, notamment les déchets liés au ballots, les déchets liés aux sangles, les sangles qui entourent les ballots, et puis tous les autres déchets qui sont liés au matériel qui sont utilisés dans le cadre de la campagne.
This is okay. So I don't know whether I had also a question on waste management or it was just for.
Yes, maybe just repeat the question again.
Yes, no, I got the question. So I think the question was on whether we'll have new upcoming vector control interventions replacing the co-interventions, and the answer to that is no. I think we have a clear strategy as a country on our core interventions that have been working, and I like the fact that we actually will utilize data to make those decisions. And so we have LLINs and IRS as our core interventions, but then again, we have the opportunity of adopting new tools. And I'll give a scenario where in Kenya, we applied the spatial repellents. We had an area of where we were doing indoor residual spraying, and we had ITNs and IRS. And then within the same locality, we had areas with high water table and we could not do IRS, implement IRS, and so they only had ITNs. And so we supplemented that area with spatial repellent. So it's more about how can we fill any gaps in protection as we put the core interventions in, or in areas where we are unable to put the interventions, which intervention is available that we can put in place. So it's more about being directed by the data and not replacing the main core interventions.
All right, thanks so much. Yes, there was a hand here. I can accommodate that question. This side, there was a hand here. Okay, yes, Hannah.
Thank you. Hannah Conker from PATH and the Reach Malaria Project. Congrats to all the presenters. I thought those were really clear, and it's really nice to see all the progress on continuous distribution recently and over the past 15 years. My question is for Kenya. Noting that in a community distribution channel, the demand from the community can be virtually unlimited. I'm wondering what the training or incentives are like for the CHWs to enter the whole counting correctly. That's also kind of a long process, or to accurately reflect the availability of nets in households. Thanks.
Thank you. And as I said, this is, I'm actually glad I was here because I've been learning from the different teams on what they're doing, because we are creating this, and as I said, we had digitized our system, and we didn't want to, as we make the changes, we don't want to reverse backwards. So it's more about digitizing all systems, and therefore that's why we even digitize and standardize how can the CHP determine the physical integrity of a net within the household. And I know you'll agree that comes with integrity issues as well, because it's a matter of them being able to physically count and input the correct one. So there's a capacity issues, there's strengthening of the systems, and supervision as well to ensure that they're doing the right. There's integrity in the process, and so I think that's it. But then also a lot of capacity building in being able, but we simplify the curriculum. When we did the pilot, they were actually able to assess, because it's a matter of determining whole size larger than your head, bigger than your fist, and then we put it in the order that you start with whole size 4, which is larger than your head, and you know the PHI adjustment for that is higher. And so as they do that analysis, if a net based on the whole sizes 4 are higher, if the PHI already goes beyond the 643, it just stops the process from continuing. So we are trying to minimize how much work they need to do in that, train them with a good curriculum that is more of using the pictures and understanding it, as well as strengthening the system to ensure there's more of integrity in the process. But it's work in progress. We are learning as we do it, as we try to create this system. And I think our biggest challenge is the coverage of the system that we're integrating it within, and the fact that it is also within a parallel division. So working with them to strengthen that arm to ensure that we have coverage of that system, and then completeness in data and all that. So those are the challenges we're facing as we try to create the channel.
All right. Thanks so much, Kofi, Dr. Falama, and Edith. Let's applause as they take their seats. Very good presentations. Yeah. So we'll have our final set of presentations, 2 of them, focusing on improving routine ITN distribution through the health facility channel. And I would like to call upon Sophia Kaufman from CHAI, and then Dominic, who will be giving us lessons from Cameroon. So Please, Sophia and Dominic, please come up. And the first presenter is Sophia. So, yes, yes.
Okay, can you hear me? Thank you. So I'm Sophia Kaufman with, as he said, the Clinton Health Access Initiative, and I'm going to be presenting today on the optimization of routine distribution and a decision tool that we've created to support strengthening distribution through different channels. So to optimize routine ITN channel delivery with limited resources, we need to evaluate, prioritize different areas and see which ones can have the greatest impact on net access and use among our target populations. And as we've been discussing the last couple days, malaria programs use routine delivery systems to get nets to those most at risk, so pregnant women and children under 5, which are a lot of our priority target populations. And as our global funding shrinks and health budgets tighten, these systems become even more critical. Sorry, I think we lost our slides. And so this decision tool will hopefully help us to think about how we can prioritize these different groups and distribute our nets with greater impact. Just trying to adjust my slides, one second.
So then, if you can help us, next slide from the technical team.
Thank you. So with fewer resources, we need to think about smarter use of our channels. This is essential for reducing malaria deaths. And so there's a few ways that we can think about how to make these smarter choices. We want to assess current routine distribution system performance, and countries need structured ways to examine their distribution channels and identify where the system is working and where the gaps exist. And with targeted action, we can have the greatest impact. We want to identify specific challenges, and a key part of this root cause analysis is to understand why certain coverage gaps exist, in addition to where they are. And third, we want to measure the impact of our corrective actions. And so CHI teams have been supporting countries with examining their LLIN distribution systems to pinpoint the areas of greatest challenge. And this decision tree tool that we've created is hopefully a practical visual that NMCPs and countries can use for a systematic way of assessing where those gaps are and what the true root causes are for intervention. So this is an image of, a zoomed out image of the entire tree. So it's relatively small, so we're gonna go into a zoomed in capture of how we can fill this out and how countries can use their available data to understand the root causes of the biggest challenges and the biggest areas for impact improvement. So this is zooming in a little bit to the first section or level of the tree. And this can be filled out with publicly accessible population level data first. So the number of pregnant women or number of children under 1 that we're targeting may come from census data or country level health data. And this may be at the national level, or it could be closer to a regional level if you're going to target your continuous distribution specifically for a certain region. And of that percentage of pregnant women or children that we're targeting, we then want to look at the percentage who access ANC and EPI services. And so this coverage data may come from your DHIS2, your MIS, and although the data may not be perfect, it will give us a snapshot of the population that we are targeting. And of those who are attending ANC and EPI appointments, then we want to look at what percentage are receiving nets or not receiving nets. So this will be our ANC and EPI delivery coverage percentages. Additionally, can come from those country resources. And as we move further down the tree, this is where the detailed data may come from in-country sources or primary research like interviews to really identify the specific root causes of a challenge. range. And so you can see here on the top the percentage of women who receive nets. This percentage is primarily made up of those who receive nets and it's given out and it's recorded, but it may also be higher than what you're looking at in the data because it may also be represented by a percentage of nets that are given out and not recorded. We're going to focus on this bottom section of those that don't receive nets because this is really the area where we can increase our impact. We want to identify why they're not receiving nets and what interventions can target that in order to improve our coverage for ANC and EPI. And so there are two main reasons or buckets of why people are not receiving nets. Either there are nets in stock at the health facility or they're not. And so I'm going to go into next those specific pathways. Continue. And one more. So this is a zoomed in picture of this second level of nets are not in stock at the health facility. And so this number is primarily based on what we would say is like a stock out percentage. The stock out percentage can be really specific to the health facility level by month, or it may be a more average yearly stock out rate or average stock out rate across regions, and that will have different assumptions with it. But if we use the stock out rate, we can understand if there are nets in stock or not. And if nets are not in stock, our question then becomes why? And so this for me is really that there are two main kinds of stockouts. What I'm calling a procurement stockout, meaning that we don't have nets at all, or a supply chain stockout, meaning we have nets, but they're somewhere else. They're not in the health facility. And so if we go down this tree and we think about the first bucket, that there are no nets at all, this can be calculated by a procurement ITN gap analysis. So how many nets were ordered and delivered compared to how many pregnant women or children need nets. And so that might identify a procurement challenge or insufficient financing. So the number of nets that were ordered doesn't match the need. And as we go down the tree, we can understand that this may be a challenge of poor budgeting or deprioritization, or it may be an issue of insufficient financing for routine nets. In terms of wrong forecast, insufficient number of nets may have been ordered because of a poor national level quantification that was done. And if we look at that procurement gap, the percentage of nets that were ordered but are not in facility may be due to supply chain challenges. So at the bottom here, you can see delivery challenges. Those nets may be at the routine level, the regional level, and it's a transport issue. They're not able to get to the health facility. Or they may have been delivered to a different health facility because of a distribution quantification that doesn't align with the new needs. So maybe there was a great population movement and now different health facilities need nets in different places. Next. The second bucket is nets are in stock at the health facility. So this percentage accounts for the nets that were ordered and are delivered but are not going out at the health facility. And a portion of those nets, at the top here you can see, may be actually going out but are not recorded. So they're not contributing to the percentage that we're seeing in the data. This case would identify that we may need to put our interventions into areas of data management or training. In other cases, nets are in stock, but they're not given out. And this could be because patients don't want it or staff don't give it out. And as we go down the tree, we can see that staff may not give it out because they may have a different guideline or prioritization understanding. They may not have guidance on when to give it out or how to catch up a certain population that's been missed. Or the nets may have been ruined in storage, for example, and are physically present and ordered, but are not usable. Next. And so this is just a snapshot of the access to nets through EPI chart. We have one for ANC and one for EPI. There's a lot of similarities, but each channel has their own data and their own indicators that we want to use. So this is a snapshot of that. Next. So you can maybe click through a little bit to get some of the data on the screen. But this is a snapshot of the ANC tree used for Cameroon, specifically for the center region. And this example is a way that we can think about the specific numbers and how countries can use them to do an assessment to really understand where the biggest challenges and areas for improvement may exist. So I'm going to average these numbers out so it's easier for our brains to think about, but in the center region of Cameroon, which has Yaoundé, it's a relatively urban setting with a large population. And so we have around 500,000 pregnant women in this center region that we're targeting. And of those, 89% are accessing ANC, which is a relatively high successful access rate. And so that's around 430,000. And this data is coming from DHIS2 2024 data, so it's our best up-to-date data that we have. And of those who are accessing ANC, that's where we want to look at who's receiving nets and who's not. So there's about 52% who are receiving nets and around 48% who are not. And so that coverage data is populated from our DHIS2. And so now our question becomes, of the 48% who are not receiving nets, our question is why? And in Cameroon, we were supporting the NMCPs to do this investigation. And we're going to hear more about that after my presentation, but this is just to give the numbers to show us which areas we need to do a little bit more investigation into. And so when we took our stock out rate of 35%, we could see that there's a big percentage where there are nets not in facility. But 65% of the time, the nets are in facility. The stockout rate we used was an average stockout rate across multiple years, because in Cameroon, there's a complex distribution and supply chain process happening over a 3-year period, where in some cases, they're relying on leftover nets or nets that have been previously procured but delivered later. And so for insufficient financing, we also did a procurement gap analysis for that 3-year period and averaged it out. So over a 3-year period, there's around a 48% procurement gap for routine nets, and around 52%, so the rest of it is due to a supply chain planning or transport delay. And so in this case, what we can know is around 65% of the nets are present, but not given to patients. So a service delivery challenge, which means if we're really tight on our budget or really tight on our resources and we wanted to maximize our impact, that may mean that we want to only focus in facility at that very last mile distribution section. And so that may be because of training or guidelines or a different understanding of prioritization between ANC and EPI. If we're able to tackle the problem in a complex way across the different sections, then we could understand that procurement is really accounting for 17% of the routine gap. And so we would ideally want to buy more routine nets for the need. And 18% are in the wrong location, so a maldistribution challenge, which is likely a combination of a supply chain quantification need as well as a transport need. So moving nets between facilities or moving nets from the regional level to the health facility level. And as we get down to this third level of the tree, this is where we did qualitative interviews to really understand why is this 65% of the nets in the health facility not going out? Or are they going out, but there's a data management challenge? And as we move through the tree, we can start to think about targeting our root causes and having the most impactful interventions. Next. So a few considerations and tips. We anticipate that this could help countries identify which gaps in the routine systems matter most to strengthen our programs with limited funding. But these trees look at gaps in access through routine systems. And it's important to also look at use in order to maximize our impact. So for after people receive their nets. These trees could also and should be used with the data that you have, so the best available data, but we understand that there are gaps in data and that there may be certain levels of data that's not accessible. But don't let the gaps stall your progress in thinking. Use this tree as a high-level useful tool to work through your understanding of problem areas and areas for strengthening. Next, these trees could and should be replicated at subnational levels to capture heterogeneity in the system performance within the country. So as I said earlier, you can target certain regions with different indicators and coverage to understand how these challenges change based on your target region. And iterate. Monitor the impact of improvements through the system and see how much further your access results can get. Thank you.
Right. Thanks so much, Sophia. Over to you, Dominic. Yeah.
Thank you. Hi, everyone. I'm Dr. Dominique Bomba, head of the Malaria Prevention Department at the National Malaria Control Program of Cameroon. After using this tool proposed by Chai, we have noticed some challenges that I'm going to present in French. So, alors, nous allons présenter les défis que nous avons pu constater sur la base de l'approvisionnement, sur la base des pratiques en milieu hospitalier et sur la base du suivi et évaluation. Alors, ce qui nous intéresse ici, c'est la distribution en routine, c'est-à-dire la distribution des moustiquaires dans les formations sanitaires aux femmes enceintes lors des premières consultations prénatales et aux enfants en service de vaccination lors de l'administration du vaccin contre le RR1. Alors, les différentes sources d'approvisionnement des moustiquaires de routine au Cameroun viennent du Fonds mondial pour 8 régions, le PMI pour les régions du Nord et de l'extrême Nord. Pour les moustiquaires campagnes, il y a les fonds de l'État. Et puis, pour d'autres campagnes, il faut avoir des partenaires comme UNICEF et ACMS en termes de marketing social. Alors, concernant les défis rencontrés au niveau de la chaîne d'approvisionnement, les moustiquaires, après production, arrivent au niveau du port de la ville de Douala. Elles seront transportées du port de la ville de Douala vers les différentes régions concernées au niveau des entrepôts régionaux. Ensuite, nous bénéficions de l'appui du Programme alimentaire mondial pour faire partie ces moustiquaires-là du niveau régional vers les formations sanitaires où les femmes enceintes et les enfants recevront ces différentes moustiquaires. Alors, en termes de stockage, les stockages à leur arrivée sont stockés au niveau du port. Lorsque les militants arrivent pas du port, il n'y a pas de stockage à proprement dit au niveau central. Elles vont directement au niveau des entrepôts régionaux. Ces entrepôts régionaux, dans le cadre du Cameroun, sont mis à notre disposition par le Programme alimentaire mondial. Et pour les régions du Nord et de l'extrême Nord, c'est le partenaire PMI qui finance les entrepôts régionaux. Donc, les moustiquaires vont partir dans des entrepôts régionaux vers les formations sanitaires où elles seront stockées lorsque l'espace le permet. Sinon, si elles ne peuvent pas être stockées parce qu'en quantité énorme au niveau des formations sanitaires, le district de santé, qui est la courroie au-dessus, fournit un appui pour stocker ces moustiquaires-là également. Généralement, les formations sanitaires utilisent tous les espaces mis à leur disposition. Parfois, c'est des salles de consultation, parfois, c'est différents magasins pour stocker ces moustiquaires-là. Alors, en termes de difficultés, concernant le transport, il faut savoir que quand les moustiquaires sont stockés au niveau du district, il n'y a pas de fonds disponibles pour faire partie les moustiquaires du district pour les formations sanitaires. C'est-à-dire que les moustiquaires partent de l'entrepôt régional pour les formations sanitaires. Quand ils arrivent au niveau des formations sanitaires, les formations sanitaires ne disposent pas de suffisamment d'espace. Il faut donc stocker ces moustiquaires au niveau du district. Mais quand ça doit partir du district pour la formation sanitaire, il n'y a pas suffisamment de moyens financiers. Donc, cela se fait souvent de façon informelle et puis motivé par les nécessités de service. Vous pouvez avoir donc dans ce cas-là des formations sanitaires qui sont situées dans des zones enclavées où l'accès peut être rendu difficile par des pluies, par des routes qui ne sont pas appropriées. Donc, en termes de difficulté, donc, il y a à ce niveau ce problème de financement-là, en termes de redéploiement district formation sanitaire, que nous pouvons noter ici et qui ressort. Alors, en termes de stockage, comme je l'ai signalé, les moustiquaires arrivent jusqu'au niveau des formations sanitaires et peuvent arriver souvent en quantité, c'est-à-dire on peut commander les moustiquaires pour l'année 2024. Elles vont arriver en 2025, en même temps que les moustiquaires commandés pour l'année 2025, par exemple. Donc, ces moustiquaires-là, quand elles arriveront, seront en quantité énorme et la formation sanitaire ne dispose pas de suffisamment de place. Parfois également, au niveau de la formation sanitaire, les moustiquaires destinés aux enfants et les moustiquaires destinés aux femmes enceintes sont stockés au même endroit, ce qui peut créer des confusions lors de la distribution des moustiquaires à ces populations cibles-là. Et comme j'ai dit, le district n'est pas concerné principalement par ce transport-là et ne dispose pas de moyens lorsqu'il s'agit de faire des redéploiements. Là, c'est quelques images des moustiquaires stockés de façon fortuite dans les formations sanitaires quand ils sont en quantité énorme et que les formations sanitaires ne disposent pas de magasins de stockage et tout. Vous voyez donc que c'est disposé soit dans les pharmacies, soit dans les salles de consultation, sur tout autre local qui puisse permettre que ces moustiquaires-là soient stockés. Au niveau des pratiques dans les formations sanitaires, qu'est-ce que l'outil nous a permis de constater? Alors, nous avons constaté que parfois, les quantités reçues par les formations sanitaires sont soit inférieures, soit supérieures à leurs besoins. Parfois, donc, quand c'est inférieur, en termes de redéploiement, les formations sanitaires vont très vite tomber en rupture. Parfois, en termes de mise en œuvre de la stratégie, les prestataires des formations sanitaires ne respectent pas forcément les directives. C'est-à-dire que la femme enceinte doit recevoir sa moustiquaire lors de la première consultation prénatale. Une formation sanitaire peut décider d'utiliser une approche marketing et dire lorsque la femme enceinte a fait toutes ses 8 consultations, on lui donne la moustiquaire de façon gratuite. Donc, il y a cette absence de respect-là. Voilà. Il y a également souvent, lors des séances de vaccination, par exemple, lorsque ça concerne les enfants de moins de 1 an, on peut sortir un ballot pour ces enfants-là. Et si le jour-là, la formation sanitaire reçoit plus de 50 enfants, vous voyez qu'à ce moment-là, c'est difficile de donner à tous ces enfants-là une moustiquaire. Donc, les directives sont interprétées de façon différente suivant le niveau des formations sanitaires et suivant le personnel. À ce niveau-là, nous avons également constaté qu'il pourrait avoir un gap en termes de formation. Concernant le système de quantification, comme j'ai dit, c'est un système généralement centralisé, basé sur les données collectées dans le système d'information sanitaire qui est le DHIS2. Donc, il peut arriver que les données soient de mauvaise qualité. Et en cas de rupture, il peut arriver qu'en termes de données, les ruptures ne soient pas captées. Donc, en termes de réapprovisionnement, donc, les formations sanitaires vont faire des demandes au niveau du district, qui va transmettre la demande au niveau régional. Et cela peut prendre du temps en termes de réapprovisionnement. Donc, parfois, le stock est disponible, mais le réapprovisionnement également prend du temps. Nous avons également des ruptures qui sont constatées, suivant d'une aire à l'autre, dû à la faiblesse du suivi et la gestion des stocks. Donc, dans un même district, vous avez une aire qui est en sous-stock, vous avez une aire qui est en sous-stock. Donc, on a également ce problème-là qui a été constaté. Alors, j'ai parlé déjà des délais dans les cas de redéploiement et l'absence des moyens financiers pour redéployer au niveau des districts. Il y a également les problèmes d'insécurité dans les zones en crise et les zones accessibles ne permettant pas l'arrivée des moyens de transport dans les formations sanitaires. Concernant le reporting, à l'instar des autres pays présents ici, le reporting part du niveau opérationnel vers le niveau central. Plusieurs outils sont disponibles au niveau opérationnel. Après le reporting, les données sont validées au niveau du district, qui transmet au niveau régional, qui valide également et transmet au niveau central, qui va consolider et puis introduire ça et puis présenter des dashboards, des situation reports et puis tous les différents outils permettant de visualiser la distribution au niveau des formations sanitaires. Par contre, nous avons encore plusieurs types d'outils en papier. C'est-à-dire qu'au niveau des formations sanitaires, vous aurez par exemple le rapport mensuel annuel qui peut être encore en papier. Vous avez la fiche de décharge qui est encore en papier. Vous avez les fiches de stock. Vous avez les fiches de mouvement de stock. Au niveau des différents services de vaccination, vous aurez le registre de vaccination qui permet de capter les données liées à la distribution des enfants au moins de 1 an en service de vaccination. Et puis au niveau des services de consultation prénatale, vous aurez par exemple les registres de consultation prénatale qui permettront de capter là-bas les données pour les femmes enceintes. Ensuite, toutes ces données-là sont introduites dans le RMA. Le RMA est saisi dans le DHIS2. Et puis, le niveau district va valider, le niveau régional va valider et partager au niveau central. OK. En termes d'adhésion aux directives de distribution des moustiquaires, il faut savoir que la stratégie étant mise en œuvre depuis 2 ans et demi, et du fait de l'enclavement, certaines formations sanitaires ne disposent pas d'outils mis à jour. Donc, si au départ, les outils étaient seulement logés au niveau du service de consultation prénatale et que l'outil a été mis à jour, certaines formations sanitaires, notamment en service de vaccination, vont tracer des colonnes pour pouvoir capter les moustiquaires distribués aux enfants. Donc, vous pouvez également avoir un turnover de personnel, c'est-à-dire les staffs qui ont été formés sont déjà partis ailleurs, ont été affectés ailleurs, ce genre de choses. Donc, cela révèle donc une faiblesse en termes de proportion de staff formés pour ces différentes stratégies-là. Et lorsque vous avez une opportunité de formation, du fait du contexte financier, vous êtes obligé d'intégrer la formation et vous ne ressortez pas principalement les items liés à la distribution de routine concernant les moustiquaires. Et puis, comme j'ai dit, dû au contexte financier également, vous avez une faiblesse en termes de supervision. Donc, au terme de l'utilisation de ces outils et ayant constaté tous ces problèmes-là, un ensemble de recommandations a été formulé, notamment en termes d'approvisionnement, diffuser un outil de planification de la distribution des moustiquaires, mobiliser des financements pour le paiement des entrepôts, aussi bien au niveau régional qu'au niveau district, mobiliser des financements pour le transport des moustiquaires au niveau de la formation sanitaire. Au niveau de la formation, mettre à jour le guide de distribution d'abord des moustiquaires aux enfants de moins de 1 an et aux femmes enceintes, développer une approche pour le rattrapage des enfants de moins de 1 an et les femmes enceintes qui n'ont pas pu recevoir leur moustiquaire lors de la première consultation prénatale, améliorer les supervisions formatives et introduire les modules de formation sur la distribution de routine dans les modules e-learning qui est en train d'être élaboré au Cameroun. En termes de collecte des données, digitaliser. La principale solution ici, c'est digitaliser ou améliorer les fonctionnalités du DHIS2 qui est le système national utilisé. Et maintenant, en termes de quantification, utiliser une approche hybride permettant d'utiliser non seulement les données du DHIS2, mais les données communautaires également et les différentes données analysées au niveau du district de santé. Concernant les initiatives communautaires, nous entendons mener une initiative pilote sur la distribution des moustiquaires aux femmes enceintes et aux enfants de moins de 1 an en communauté par les agents de santé communautaire, permettant de rattraper les enfants de moins de 1 an et les femmes enceintes perdues de vue. Il faudrait également trouver des financements pour les cliniques mobiles dans les zones en crise qui permettent de rapprocher les moustiquaires des utilisateurs du fait du contexte sécuritaire. Sur ce, je vous remercie de votre aimable attention.
All right, thanks so much, Dominic. Yes, you've been able to save us some time for our Q&A. So it's now time for our questions. I think we have about close to 10 minutes. Yes, less than 9 minutes for questions and answers. So, Hans? Okay. Okay, 1, 2. Okay, let's take the first 2 and then, yeah. Just go ahead.
Ok, merci beaucoup pour la présentation. Donc, moi, je suis Damjigle Théophile, je suis du Togo. Je voulais demander au présentateur comment sont gérées les ruptures, vu qu'il n'y a pas un mécanisme d'approvisionnement des formations sanitaires à partir du district. Quand ces formations sanitaires-là sont en rupture, comment ces ruptures-là sont gérées? Et est-ce que vous avez une idée du nombre de jours de rupture maximale que vous avez notifié au niveau des formations sanitaires? Deuxièmement, c'est de voir est-ce que, bon, nous, on a une pratique, je ne sais pas si je peux partager avec vous, pour le stockage des moustiquaires, au lieu de les stocker au même endroit, nous, les moustiquaires qui sont destinés aux femmes enceintes, on les stocke au niveau de la maternité, et les moustiquaires qui sont destinés aux enfants de moins d'1 an, on les stocke au niveau de du service de vaccination, pour que lorsque les enfants vont venir en vaccination, donc on puisse les céder facilement les moustiquaires. C'est ce que nous faisons chez nous pour éviter que les moustiquaires soient stockés au même endroit. Merci.
The second question.
Thank you for the presentations. Chris Warren, independent consultant. I work in the logistics industry. Just it's a suggestion. I welcome your feedback. We often hear about the challenges with the securing of warehousing space, transportation, the contracting of transportation. I'm just wondering if you have experience or if you've thought. This also applies to the presenter from Côte d'Ivoire, of engaging with local national organizations such as the High Commission or the National Organization for Transporters or Logistics Service Providers during the macro planning phase to get their strategic insight as to how best to manage this, rather than directly engaging them in a contracting format, but rather engaging with them as a strategic partner.
Dominic, go ahead.
Merci pour toutes ces questions. Alors, comment sont gérées les ruptures? Il faut savoir que les données de gestion et approvisionnement des stocks sont captées au niveau du rapport mensuel. Donc, dans le rapport mensuel, vous avez des items liés à la gestion et l'approvisionnement des stocks. Les données donc vont être saisies dans le RMA, introduites dans le DHIS2, validées au niveau du district, validées au niveau régional et transmises au niveau central. Voilà, maintenant, en fonction des difficultés structurelles, le nombre de jours peut varier. Nous avons par exemple eu les régions du Nord et de l'extrême Nord qui étaient exclusivement financées par PMI. Donc, après le Stock Work Order, les régions du Nord et l'extrême Nord sont entrées en rupture de moustiquaires imprégnés au bout peut-être de 3 mois. Et la rupture peut aller pratiquement jusqu'à de l'ordre de 4 à 5 mois dans ces régions-là, le temps que les mécanismes de contingence se mettent en place. Donc, c'est vrai que par moment, il y a eu des redéploiements interrégions, mais la rupture dans ces régions particulières-là, particulièrement ces régions-là, a mis un peu plus long. Mais sinon, les données sont captées de façon mensuelle au niveau du DHIS2 et analysées suivant également ce délai-là. Maintenant, concernant les pratiques, les moustiquaires femmes enceintes conservés en maternité et les moustiquaires des enfants de moins de 1 an en vaccination, c'est ce qui se fait de façon commune. Maintenant, si vous attendez les moustiquaires de 2024 et que vous recevez les moustiquaires de 2024 et de 2025, vous avez beaucoup de moustiquaires qu'il faut stocker quelque part. Donc, c'est pour ça que, comme vous avez vu les images là, vous pouvez avoir donc des déficits d'entrepôts et des déficits de locaux au niveau de la formation sanitaire. Mais pour les séances de consultation prénatale et pour les séances de vaccination, un stock donc est pris dans l'entrepôt de fortune et déposé donc au niveau des services de consultation prénatale et au niveau des services de vaccination pour la séance. Mais de façon routinière, un autre local sert d'entrepôt pour ces moustiquaires-là. OK. Maintenant, pour la question concernant les discussions avec les différentes entreprises ou autres ONG proposant des services logistiques au niveau du pays, au lieu de les engager formellement lorsque les moustiquaires, je pense que c'est une pratique que nous allons adopter parce que ce n'est pas généralement ce que nous faisons. De façon routinière, nous bénéficions de l'appui du PAM pour le transport des moustiquaires de routine. Mais peut-être, au regard du contexte effectivement financier, il serait opportun également d'engager toutes les différentes structures logistiques pour voir peut-être laquelle d'abord propose la meilleure offre et puis voir comment donc amener ces moustiquaires-là dans des entrepôts. Et puis voilà. Mais de façon générale, les entrepôts au niveau régional sont fournis par le Programme alimentaire mondial. Et c'est le Programme alimentaire mondial qui transporte ces moustiquaires-là jusqu'au niveau des formations sanitaires. Mais comme je dis, et j'insiste là-dessus, je retiens justement la recommandation de convier sur la table les différentes entreprises logistiques locales qui proposent également ce genre de services. Merci.
All right. Thank you so much, Dominic and Sophia. You may take your seats. Let's applaud them. We've brought the presentation sessions to a close, and I'll hand over now to Jason.
Good. I wanted to thank Prince for bringing us in on our last session actually ahead of time. So Prince, thank you very much for excellent moderation. Much appreciated. So look, I'm going to invite Marcy up to do the final closing presentation and key messages from AMP. So over to Marcy. You got a flicker if you need it.
Hi. Everybody shattered? I'm definitely shattered. I'm going to go quick, but I hopefully will not speak quite as quickly as Dr. Bomba. I think we may be in competition for the fastest speakers in the room. But I'm going to go quickly. You all know that the slides will be available afterwards. So there's lots of stuff I'm going to jump, but you can pick it up later, and you all know where to find us. Okay, so this has been a repeated message, I think, over the course of the time we've been around in the room. We need to think about both the selection of the ITN type and the optimal mix of channels, because we're talking about impact. And I think impact is a word you've all used quite bizarrely over the course of this week. Nothing was impacted. What does that mean? What does it mean that you cut your costs and you did your intervention? What do you mean when there was no impact? What have you evaluated to say that there is no impact? So be careful saying that there's no impact to cut costs, because the message coming across to all of your funding partners is, well, then we just keep cutting. But you don't know. You don't know the impact yet, guys. We're still getting started on this process. So again, you're going to need to look at a data-driven continuous improvement culture where the channels that you do select can be reviewed, adjusted, added, dropped, while you're looking at your ITN access goals and your impact on malaria. Impact, again, is a long-term indicator. In this environment where we're resource constrained, optimizing the ITN distribution through campaigns and continuous distribution channels will, as per the panel yesterday, require a paradigm shift. We're not trying to achieve 100% access and use. We're trying to get to optimal coverage. And again, impact is a long-term indicator. It's not what happened. You delivered yesterday. There was no impact today. So please, let's think about those words. I'm not going to go through the slides one by one and not every bullet. You know the story of where to find them. Key message 1, I've got 5. So we're trying to achieve impact on malaria. Again, this is a long-term objective. We're not trying to achieve universal coverage. You need to determine what you can achieve in terms of impact with the resources that you have. And this is likely going to mean that you're going to need to change your targets or differentiate your targets based on subnational data burden and what you decide to do in each area, and then what you need and are trying to achieve. So I'm coming back to this slide. This is the map tool. I chose Nigeria. I know that on day 1, the quality of the presentation that Tasman gave wasn't very good. This is an excellent tool to balance out, if I withdraw my nets, how much more money do I need for case management? And this is the objective of this tool, because no matter what we do, if we have no nets, we're going to need a lot of case management. And somewhere in there, there's a trade-off and there's a sweet spot. And you're going to need to try to find the sweet spot on how much can I reduce my coverage of vector control without exploding my needs for case management. Key message 2, denominators matter. Some of you countries in the room are not going to love these examples. The denominator you use, it drives the number of nets and the amount of human and financial resources that you need. I mean, that's clear. I don't think we have a question on this in the room. So if we control the denominator, we can also help to control what we need in terms of resources. So what drives ITN distribution costs? In any channel that you are putting ITNs through, what is driving the major cost? The net. So if we can buy less nets, we can, figure out where we're going to put extra money. So it doesn't matter whether it's routine, school, community, campaign, private sector. The cost driver of every system for nets is the net. The more you buy, the more you spend. We're all clear on that, right? Sorry, I need to switch. Yep. Okay. So with no countries being named in the room, of course, there are 29 of you. You'll figure out which one of you this is. This is example 1. So I just wanted to walk you through, and I chose 2. I could have chosen a lot more. As you know, I review almost every one of your macro plans. Every one of you gets feedback from me. So you will have seen some of these comments. Country 1, census in 2022. How many years ago is that? 4? Yeah? So then we had a 10% contingency based on WHO recommendations, but I think we'd all agree that recommendation is for countries where a census is more than 5 years old. So somehow we slipped in the 10% for the WHO recommendations. We slipped in another 10% based on our registration data. We slipped in 6% on security stock. So by the end of all of this, you've adjusted that population census number by 26%. I did a really just kind of conservative costing. So the total additional cost linked to that is in the bottom right. You don't have any money, guys. So we can't just increase by 26%. Example 2, a little bit worse, and country may be in the room. Here, you ended up with your adjustment. Your population in your country was now 30 million people, except your official number was 24. So when you did that, you actually lost $17 million US by inflating that denominator. And that's a conservative estimate because I'm estimating 60 cents a net for distribution costs, and a lot of you aren't there yet. So, all to say, denominators matter. So, if you can't control the denominator, maybe you want to look at a different channel. So schools have a much cleaner denominator. Maybe that's a better way for you to go. But you're going to need to compare the needs, so your ITNs and your funds, against what you can achieve in terms of access and impact. Key message 3. Reducing costs does not mean missing targets. So a lot of people have spoken. I really want you to think about when you're reducing, there are going to be things that they're non-negotiable. Like you can't cut it. If you cut it, you're not going to hit your target. So don't cut it. That's not one of the things you can cut. So I think you really have to think about what you're cutting within a risk and mitigation framework, because otherwise, just cutting on the basis of an Excel file and what you're looking at in terms of numbers, it's not the smartest way to go. We have to put that into a different framework of what we're trying to achieve, impact, and also just not making a mess for you all when you're trying to do your operations. These are the slides I'm going to go through real quick. We've done a lot of work over the last year. The first one, I really want to highlight the contributions of all of the malaria programs that have contributed to this. We ran 7 90-minute webinars. So you contributed a lot to this guidance on how can we cost optimize for campaigns. It's available in all 3 languages. It's part of the Global Fund Grant Cycle 8 guidance. And there are elements applicable there probably to your SMC campaigns. So you may want to pick it up and check it for that. This is just what's in it. So this is the campaign optimization guidance. It's interactive. You can go through it. You know, it's up and down. You can skip areas that you're not interested in. Then we have, if the slide changes, oh, there we go. Okay, this is a cool tool. Steve is here. Steve, back, see him there. Steve has put this together. This is the ITN Allocation Strategies website. This gives you some ideas of what you can do and what it's going to mean in terms of what you can achieve. See if the slide goes. Yep. This is fake numbers, okay, so it's not real. I use Burkina. I know you don't have 1 million people in Haut-Bassin. But what I wanted to show you is on the right-hand side, you can save your entries. So if you look like at the top line, it's 1 net to 2 people with no cap. So that's our ideal scenario, right? We're going to hit 100% access. And each one of those sublines gives you a different idea of what your net need would be and what access you can potentially achieve if you change that ITN allocation to households. If you're going to maintain campaigns, if you're going to look at going to lower coverage campaigns, if you're going to look at changing your allocation, I do suggest you use this tool, and I'm sure Steve would be more than happy to chat with countries if they're interested. Again, I'm not going to spend time on this. There's guidance on the website. Everything is linked from the presentation on channel selection, so how to do some of the assessments you need to do to think about, you know, how do we select different channels and move beyond our 3-year campaign and routine as a status quo. We have a whole toolkit that's come out with adaptable tools on school-based distribution. Each of the pieces of guidance we're putting out now, they do come with adaptable tools, so documents in Word, templates, Excel, to make it easier for you to pick it up and use it without having to do a significant amount of work. I do just want to note and thank the Continuous Distribution Working Group, so Ketty, who's in the room, Prince, others, Christian, who have been working on this, Mary Conte, Steve, Trop Health, Eleanor. Lots of people have worked on this to get this updated, so I hope you'll find it useful. It's going to switch. Okay, and then just picking up on the last presentation from Chai and from Cameroon, there is a document that's recently come out on strengthening routine distribution that's really focused on the gap areas we see for routine. So it's all there. Key message 4, we're not going back to a well-resourced future in the short term, okay? Like where we are is where we're gonna be for the coming years. And so don't pretend that all of a sudden tomorrow we're gonna have a whole bunch more money coming into the system. So we need to innovate, we need to experiment, and we need to figure out what works for that impact on malaria. Key message 5, it's the last one. I'm going to get us out of here on time. We need to share better practices, but also we need to share the things that don't work, because this is an experimenting process. Not everything's going to work when we try it the first time, but we need to learn together. And if we can learn together, we can do a lot as a community as we go through this process of significantly changing how we're going to plan and implement vector control. And this is really a key message for all of you. If you come out with innovations, if you come out with fails, tell us and let's present on it and have people talk. I'm closing with this quote from Mark Carney from a speech at Davos this year. Nostalgia is not a strategy. It's just not. So we need to think in a different way. From where we are, we can build something different. It's not going to be the same, but hopefully we can still achieve our equity, and hopefully we can still get nets and vector control to the people who need them and work as a community to ensure we have that impact on malaria. Thanks. Sorry? No. No, we don't do questions because everybody's tired. It's prayer time. It's the holy month of Ramadan. People need to go home. I'd like to call up David Gittleman, Hannah Conker, Jessica Rockwood, and myself. I'm going to call myself up. And I'd like to call up La Côte d'Ivoire. The first award for this year's meeting is going to the Ivory Coast. First, for the work that they're doing to try to look at optimizing their campaign channels. And second, to encourage them to do a good campaign coming up as we move into a resource-constrained environment. So I'd like you to come up, and David would give you your award for this year's meeting.
Attendez, on cherche les
I don't know. Who's giving which one?
Okay.
Okay, so just again to recognize the work that Côte d'Ivoire has been doing, to encourage them as they come into their 2027 campaign thinking, and wish them luck as we go through this process. So Côte d'Ivoire, congratulations. Wow, there's a total photo shoot this year. It's a photo shoot this year, I didn't know. Okay, for the second award, I'm calling up La Guinée. I would like to provide an award. We'd like to provide an award to Guinea this year. I think we were all extremely impressed by the presentation, and really this award goes to Guinea for its use of data for decision making, and all the work that they have been doing to strengthen their digitalized system and really build on that for a future that will be much more efficient and effective. So Prof. Alioune Camara, please come up, and Hannah will give you that one. Okay, and for award number 3, I'd like to call up Malawi to come up. So we are awarding Malawi this year for the work to support the EKIS, as you call it, the Electronic Community Health Information System, to be thinking through the innovation of new approaches and how to leverage that community health system, and again, to encourage you to continue to learn and to share those learnings with the rest of us. So congratulations, Malawi. And I do want to note for Malawi that Drake Zimmerman from the Rotarians has been online since midnight every day for this meeting. He's very tired now. But I do want to acknowledge that he was talking about the presentation that was given for Malawi this year and where they were in 1994 when he was still working with them, and to note the huge improvements that he saw on your slides. So he was emailing us frantically about Malawi's work. So congratulations. The last award is a special award. It goes to Sudan. Our last award to Sudan, we awarded them in 2023 for all of the work that they had done. The war had just broken out, some like in the back there where they're doing coffee. And so therefore they were not in person to come and receive their award. Can you actually come up and give it? Can you come up and do it? So I wanted to ask the Sudan team to come up. I think they've done excellent work. No one has asked them a single question on 2 presentations of 10 million nets going out in the middle of a war zone. But I want to really acknowledge the hard work that's gone in and the recommendations that have come out on future thinking for ITN distribution in conflict settings. So Hamuda and team, please come up. Thank you, Ivan. Okay, and now we get to the fun part, the part you all love, the capes. Capes are always fun. So, cape number 1, Team Cameroon. We are giving Team Cameroon a cape. 2 reasons. 1, you finished your campaign in less than a year. Go Cameroon. And 2, you're doing some work to strengthen your other channels. So Cameroon, up for a cape. He's much taller than you. You've never been here for these in a while. Yeah, avoid the projector, you're in the lights. Yeah, there, you're not in the... So congratulations to Cameroon. It was a lot of pressure to get that campaign done in less than a year, and really you guys pulled it off, so well done. And I'm not sure if he's here. Is Niger in the room? The man who's taller than Cameroon? Dr. Ubandawaki? Okay, I don't know that they're in the room right now, so we will skip over. Andrew Glover, the napkin exercise wins you a cape. Come on up. I do have Niger, so we'll do Niger first, and then we'll do Andrew. So I think Andrew woke us up this morning, gave us a little light mathematical modeling. So I think we wanted to just acknowledge his work on the subnational tailoring that's being done. And our last cape today, I actually walked around the room and asked people who they thought should receive awards this year. It doesn't mean I listened to you, but I did actually ask you. Our last award is going to Fatima and Team Nigeria. Just lots of people very happy to see the EOL Nets work, the thinking through the channels, the cost optimization. I mean, Nigeria has a lot of advantages that you don't have. They roll campaigns all year round, so they're able to learn all year round, but they bring that back to us and they let us all learn from what they're doing. So I think thanking Nigeria for the work that they've done, and again, encouraging them to do more. That's it. Okay.
Yeah. So just a few words to close. If Marcy, Oriane, and Robert, well, a lot of people are standing, but Marcy, Oriane, Robert, and Marcy, could we just give a round of applause to them? The 3 of them have done so much work. And it's just an interesting anecdote. A few months ago, Marcy and I were interviewing interns. We had this young intern, we had to do an icebreaker. So I told a story about a wise person in this room, Mark Grabowski, who said, at some point, Marcy Erskine will be so famous, she will just be known by her first name, Marcy, like Cher. So we tell the story to this intern, really sweet, really young person who says, well, I've never heard of Cher before, but is she like Zendaya? And we're like, yes. So we have kind of Marcy, Cher for older people like me, and then Zendaya. So thank you very much, Marcy specifically, Oriane, Robert, for the work. Just 3 quick points. Can people please do the evaluation? We only have 30% of responses to day 1 and day 2. It's really important we get responses on the evaluation, both because we've done a joint meeting and just how this went. So you'll get, the QR code is there. You'll also get an email today. And then just 2 more points. You would have received an email late last night about your airport transfers. So click on the link. It'll list your name and the actual time you're going to be transferred. If you need to change that, there's a hospitality table at the main reception. You just need to go to that hospitality table and ask for that change. And last thing is, Oriane mentioned all the presentations are currently up on the AMP website and photos. So thanks again, everyone. Thanks to you for joining us virtually and also joining us in person. and we will speak again next Wednesday on the weekly call. So thank you very much.